Good morning, everyone. Just really delighted to see such a nice crowd here on a Saturday morning to join with us in celebrating the career, accomplishments, legacy of Dr. Kevin Martin here at St. Louis University. And prominent among his accomplishments over the more than 30 years of leadership of the division here was creation of the renal fellowship program here. And coincident with Dr. Martin stepping down from leadership of the division just this past winter, we also graduated our 100th fellow in this program that Dr. Martin founded. And so we want to take today to recognize Dr. Martin and the productivity of celebrate the fellows. And we're happy to see the number of present and ex-fellows from our program who are here today. But to provide really appreciation for Dr. Martin's impact here, we first need to acknowledge Dr. Coy Fitch. Many of you might not know who he is, but he was the chairman of medicine here for many years, starting in the 80s. And shortly after assuming leadership of the department, Dr. Fitch embarked on a very aggressive recruitment of young, accomplished, ambitious people to lead the various divisions in our Department of Medicine. And though that cohort of leaders and intellectual leaders for our department completely transformed St. Louis University. And within a few years, where there had been none, there were NIH-funded investigators in many of the divisions of our department. It completely changed the landscape. But among those recruits, I think one could make a strong case that none has had a more long and lasting impact than Dr. Martin. So Kevin joined, Kevin earned his medical degree at University College in Dublin. As you all know, he's from Ireland originally. And he did an internship in medicine in Dublin at St. Vincent's Hospital. But then something amazing happened, and for reasons that are hard to fathom, Kevin decided to move to St. Louis. And here he repeated his medicine training at Barnes Hospital, and then embarked on training in nephrology under the mentorship of Dr. Eduardo Slatopolsky. And in that time, he created himself as a leading expert in PTH, metabolic bone disease, calcium phosphorus, and chronic kidney disease. And in the remarkably productive few years when Kevin was on the faculty at Washington University, he became a nationally and internationally known expert. And so at Washington University, he started on as an instructor and rose through the ranks and continued this remarkably productive investigative career. Dr. Fitch was able to recruit him to lead the division here at St. Louis University in 1989. Here he had already established himself as a clinician, a translational investigator, and even a proto-interventional nephrologist, because I understand he was responsible for many of the kidney biopsies when he was at WashU. But here at SLU, he developed his own and developed his own research programs. He organized and fortified the clinical work of the division, and he himself recruited then a cadre of clinicians and scientists as faculty, and that's continued to evolve and thrive over the years. He also organized and led the Nephrology Fellowship Program, producing a series of nephrologists whose careers have had impact both locally and across the nation. So as a member of the faculty on two different stints in the past 20 years, I've had the privilege of observing Kevin's leadership and benefiting from Kevin's leadership. And it gave me plenty of opportunity to reflect on why is Kevin such an effective, charismatic leader. Initially, when I first met him, I thought, well, obviously it's his accent. It's irresistible. But soon came to realize, of course, that Kevin's skills in leadership go way beyond his ability to tell a good story, which are real. That is quite a talent he has. But in my opinion, there are several specific things that Kevin has done that allowed him to be so successful as a leader in our School of Medicine, in our department. First of all, his just credibility because of his mastery of the subject matter. And whether it's clinical work or scientific ideas or problems, there's never been any doubt that Kevin is a thought leader in our group. And why is that? It's intelligence, his training, his experience, but his lifelong commitment to ongoing learning is what's very impressive to me. And I'm continuously, or frequently, I should say, astonished by his critical reading of the current literature on issues that maybe be unrelated to his expertise exactly, and creative ideas in response to these things. So his ongoing learning, commitment to learning, and willingness to adjust prior thought habits in response to new information, I think, is so critical. A second key feature that Kevin has, and it's related to what I first mentioned, is his habit of just cheerful optimism. And it gives everyone around him the idea that success is possible and success is worth the risk, and inspires people to be positive and to believe in themselves. His ability to render work not only tolerable but joyful is a critical asset. Third is his resourcefulness when faced with difficulty, and there's many examples of this, but just one, it's obviously, is that his development of interventional nephrology here happened when there was a crisis in the interventional radiology program. And what are we going to do? There was no access to lines and so on. Kevin had the confidence, the knowledge, the skill to do it, and he made it happen. And it's been a wonderful thing for our division and for our department, I think, ever since. And then finally, I'd like to say that an important asset, at least with my interactions with him, and I think with the division as a whole, is his reliability. And that he's there and he stands behind his commitments to, and without that, no one could sustain success for such a long period of time. It's a critical thing. So, in honor of Dr. Kevin J. Martin, and in celebration of the training program he founded, we'll proceed with the day's activities. The next person to speak will be Dr. Krista Lentine, and she's, since January, has been serving as the associate director of our division and has played really important roles in many aspects of what we do. If those of you who don't know her should realize that she is just the example par excellence of a person whose career has grown and developed during Dr. Martin's tenure. And she's a national and internationally renowned expert in big data solutions to many problems, particularly in transplant, and her influence has now extended to policy decisions and governmental issues. Her work's been published in the most prominent journals. So I'd like to welcome Dr. Lentine to the podium, who will introduce the first speaker and make some remarks.
Good morning, everyone. Thank you, Dr. Edwards, for that beautiful tribute to Dr. Martin, and we'll be doing that throughout the day. But I'm really deeply honored to join Dr. Edwards in welcoming you to the St. Louis University Nephrology Division Inaugural Festschrift Symposium honoring Dr. Kevin Martin. And folks have come here together today from both near and far, and we're delighted to have each of you with us today for this very special day. And when Dr. Edwards and I began thinking about how we would honor Dr. Martin's career back in the spring, I raised the idea of holding a Festschrift. And this is a new event for the university, and we received some feedback from colleagues that they had never heard the term. So I wanted to take a moment to discuss the meaning of a Festschrift and why it's so fitting for our event today. So a Festschrift refers to celebrating the works of a scholar, often amongst close colleagues. And while in the original German definition, the celebration often occurs in written form, the tradition has evolved at many institutions in the form of a public celebration. And we thought, what could be more fitting than having an inaugural university Festschrift honoring one of the most impactful nephrologists and division directors, not only at our university, but across the country. For 33 years, Dr. Martin has led our nephrology division, And we'll hear more about his journey and his reflections, but some highlights include 33 years as a division director, establishing a nationally regarded interventional nephrology program, pioneering work in bone and mineral metabolism, more than 250 Medline referenced publications to date, if I've got that count correct, and numerous chapters and editorial board service, as well as other levels of impact. So many of you here today have been touched by Dr. Martin's work and life as a teacher, a mentor, a colleague, a physician, a family member, or a friend. And I personally have worked at St. Louis University for 17 years. This was my first job out of fellowship. And the fact that I've stayed speaks to the sense of community and work family that Dr. Martin has fostered in our division. And that's a common theme. Dr. Bastani may hold the current record, perhaps followed by Dr. Philipneri, but many of us who join tend to stay long-term because we share that true sense of community and loyalty to our patients, our institution, and to each other. And we have fun together. Christmas karaoke is an annual tradition at the Martin Nephrology Christmas parties. And we do have some of the karaoke stars in the house. Dr. Alvarez and Dr. Mayer, we may bring out the microphones and music later on for our enjoyment. So our esteemed guests include Dr. Martin's family, one of our SLUNephrons former faculty, Dr. Esther Martin, their daughter Jessica, who's heading towards a colleague and possibly a pre-med student, as well as Dr. Martin's children, Kiara Shaver and Dr. Alan Martin, have come both from out of town and locally to join us here today. So we want to give a brief overview of today's program and some of the thought that went into this design. And again, as a new event, we had a lot to learn, so we ask for your grace if there are any errors or omissions, but appreciate that the planning was a true labor of love. We have 3 nationally renowned speakers who were chosen because their work and expertise reflects an area of Dr. Martin's career. Our first speaker, Dr. Mawla, was a SLU fellow in 2006. He was actually my first fellow on the wards, and we are so proud that he has gone on to become a leader in interventional nephrology with a highly successful practice in Dallas. Dr. David Bushinsky shares Dr. Martin's expertise in bone and mineral metabolism and will give a wonderful talk on bones and stones. And Dr. Sharon also has expertise in bone and mineral metabolism, but notably has risen as a prominent woman in nephrology and woman in academic medicine. She's an associate dean of translational research and is going to be talking about uremia and cardiovascular disease. And as Dr. Edwards mentioned, another recent milestone for the division is that we've recently graduated our 100th fellow from the fellowship program that Dr. Martin built. And you'll be hearing from our fellowship director and associate director, Drs. Vo and Philipneri, about some of the recent accomplishments of the fellowship program, as well as reflections from 3 of the past fellows in the cohort, including Dr. Usman, who's joined us, and Dr. Caliskan, and Dr. Elewa is also joining us today. We're grateful to have university leadership, Drs. Nayak and Montaño, join us for a service plaque presentation to Dr. Martin and share some highlights of the clinical impact as well as the research productivity of Dr. Martin and of our division. And then we'll wrap the day with our keynote presentation, Dr. Martin's reflections of 50 years in nephrology, and that's going to be a wonderful reflection. So putting together an event takes a team, and we wanted to thank our program committee who devoted many hours with me over these months putting this event together, including Dr. Edwards, Amy Mossman, Dr. Caliskan, Kenan Mayer, and Ariel Schnell, as well as others like Dr. Philipneri, who helped with the CME certification, our chief fellow, Liz Memon, and other fellow volunteers, as well as Kathy Hollinsworth for some great support. And holding a conference certainly requires support, and we're very grateful to our sponsors. We're delighted to welcome 15 unique sponsors, including our presenting sponsors, Aurinia and Travere, our fellowship-level sponsors, Alexion, AstraZeneca, Caladitas, CSL Vifor, and Mid-America Transplant, as well as our exhibiting sponsors. Again, thank you for your support. So again, thank you all so much for sharing your Saturday with us. For our division, this is a precedent-setting event for a precedent-setting leader. And we're delighted to come together to celebrate Dr. Martin's legacy and how it will always be foundational as the division continues to grow and evolve to take on new challenges. And so it gives me great pleasure to welcome our first speaker, Dr. Neghae Mawla. After completing residency and fellowship at St. Louis University in 2006, Dr. Mawla joined Dallas Nephrology Associates. He is passionate about vascular access preservation and creation. He serves as the director of the Endo-AVF program for Dallas Nephrology Associates and medical director of the DNA Vascular Access Center. And as I mentioned, Dr. Mawla was my first fellow on the wards, and I have fond memories of how he kindly oriented me to the hospital and how to get things done. He's grown into a well-regarded speaker. We had the opportunity to get together at the recent National Kidney Foundation Spring Clinicals in Boston. I remember sitting together saying, I want you to come and give a talk to our fellows, and I'm just delighted that it has come together in such a special event. Neghae is also a father of twins, and he kindly mentored me when I had twins just a year later. Among his fun facts, he is a barbecue aficionado and competes in barbecue competitions and has his own special line of barbecue rubs, so we'll all have to check that out in line afterwards. So again, welcome Dr. Mawla, SLU graduate, vascular access expert, and good friend as well.
Thank you for putting this program together, and it is an absolute honor to be here in front of Dr. Martin, Dr. Gonzalez, Dr. Bustani, Dr. Edwards, of course Dr. Lentine, Dr. Philipneri, everybody else that was a mentor for me on my path here. I never in a million years thought I would be here to honor Dr. Martin on his way out. I never thought Dr. Martin would leave, but that's a different kind of story. I do have a few disclosures. For those that know me, you can see research is on there. I knew how I used to be about research back in my fellowship days, but everybody changes and evolves. I was part of the Medtronic, or at that time, Avenue pivotal trial for the Ellipsis device. I'm part of the BD post-market study for the Wavelength device and a couple of other trials along the way. Dr. Martin, what can I say? You know, everybody leaves you with a little something that you carry with you forever, right? With Dr. Philipneri, it was always, you know, she was the person I went to about CMS and policy. Nobody understood that like her. You know, Dr. Lentine and Dr. Bustani were my transplant gurus. Dr. Edwards, I took the bow tie from him. I finally wised up enough to say, you know what, life is better with a bow tie. Dr. Martin remembers I never wore a tie, and it drove him crazy. I mean, I would do the scrub tops with khakis, and I know he was not a fan. I heard from subsequent fellows. So, but the thing I carried away from Dr. Martin is torques are for wimps. Anytime, so a torque is a little device that helps to rotate the wire to get it into a better position during a case. And if the wire doesn't go where you need to, this is specifically required, you know, you put it on the wire and you just turn it, and it turns the wire accordingly so you can get where you need to. And every now and then I'd be like, Dr. Martin, do you want a torque? It's like, no, torques are for wimps. To this day that I still say this, we just had a new interventionalist join our practice, and so I'm kind of proctoring him, and he asks for a torque. And he said, do you have any? I said, I've got one, but torques are for wimps. He's like, I'm no wimp. And this and all bleeding stops eventually, right? I don't know if those are two things he still says. It's like all bleeding stops eventually. Just keep holding. Yes, it is absolutely an honor to talk about innovations in kind of interventional nephrology. And I think really to talk about innovations in the interventional field, we really have to go back and look at innovations in other fields. And I think when you look at endovascular fistula, which is really what I've kind of picked up as my niche and passion, you look back at laparoscopic cholecystectomy days. When lap choles came out in 89, 90, there was a big resistance from the surgeons, right? And this was a review article that was put out after 10 years of laparoscopic cholecystectomies. And, you know, and so that's why I kind of said, do I look at it saying, you know, do I want a lap chole or an open chole for my patient? I mean, what kind of question is that? Lap choles are the standard, right? Nobody thinks about an open chole anymore. But look, and you can see in the literature, it was published, circus surgery, right? The early literature said, this is crazy. You guys cannot do this. But what drove it to success was actually the patients. It was not the physicians that pushed for it. It was the patients that said, this is what I want. I grew up in a small town in Texas, and so I knew some of the surgeons there still. So I asked them when I was kind of pulling up this article, I said, hey, do you remember when lap choles came to Amarillo? And they said, oh yeah, it was a weekend session. They put all 12 of us in a room. They sat us down for a day, and they said, there you go. I was like, and? He said, I assisted in the first lap chole. It was 4.5 hours. And I was like, and? He's like, I watched people get converted to ICU. People get converted to open. It was a hot mess. I said, no way am I ever going to do it. I said, but you're a laparoscopic surgeon now. What happened? He says, well, 6 months later, patients would come to my office. They're like, are you going to do this laparoscopically? He's like, no, I don't believe in that. They'd leave. He said, I realized that in order to stay pertinent as a physician and a provider, I had to make this work. And I think endovascular fistula is the same thing, right? There's a lot of resistance because we don't like the way it looks. We don't like the way it feels. We don't like the way it sticks. Give it time. Give it 10 years and come back and say, okay, now let's look at it and see, right? Same thing happened with fistula first, right? When suddenly the country was 95% grafts and all of a sudden everybody has a fistula. And the dialysis clinics are like, you want me to stick what? I mean, now there's no problem with the surgical fistula. But the endovascular fistula, it's, you want me to stick this? What? So it'll come. You just got to give it time, right? So as an interventionalist, what do I need? I need a needle wire and an ultrasound machine. I mean, that's it. If I have that and I have those skills, I can do everything. I can do my angioplasties, I can do my declots, I can place catheters, I can place PD catheters. That's it. And I think that's why, going back to what Dr. Edwards said, Dr. Martin, when he says, well, IR's gone up and left, this happened right around the time I was coming to SLU, was, IR used to do all the endovascular work for the department, if I remember correctly. Transplant surgeon did all the open access work. The vascular surgeons were not real keen on doing dialysis patients. And so, well, he's like, I can do a needle and a wire. And sure enough, he has built one of the strongest programs. Now, Dr. Martin is a bone guy, has always been a bone guy, as you mentioned, and will always be the bone guy. And I think if you look at his 250 plus publications, probably 95% of them are metabolic bone disease, not interventional, right? He stays very low key on his access work. And so if you leave St. Louis, and if you leave, his name is out there, they know, but they don't know. They're like, who is at SLU that puts out, because St. Louis University has leaders across the field now. Dr. Alvarez is here, he's one of them, right? And finally I was at a meeting and people were like, you guys are, who is at SLU that's doing this? Because we don't know them. I'm like, yeah, that's Dr. Martin. Why don't I know his name? Oh, he's a bone guy. He just does this on the side, right? So, but even if Dr. Martin's name is not out in the interventional nephrology, among interventional nephrologists, his legacy definitely is. And that's proof with Dr. Vo, Dr. Alvarez, Dr. Ghazi, Dr. Marcaseri, Dr. Maya, right? Dr. Forescu. I mean, so many hands that are leading this field have come through Dr. Martin's hands. So when I think about innovations in vascular access that have come over all the years, there's kind of three things that I think about. Okay, a procedural innovation, something that doesn't really change outcomes, something that doesn't really change the end game, it just makes it a little bit easier to do. PD catheters, for example, back in our day, we did peritoneoscope, blunt trocar, force it in, take a peritoneoscope, look in there, drop the PD catheter. Oh, it was traumatic. But now it's all over the wire. Now it's needle, wire, you can drop the PD catheter in, right? Thrombectomy devices, there are multiple ways to do a declot. You can go simple balloon angioplasty or you can use fancy devices. They all work the same. It's just a matter of how quickly and how convenient you want to get done. And there are multiple thrombectomy devices that are on the market and coming on the market, and they're always trying to get, because an IR declot's about 2 hours. I mean, I don't have time for that when I've got 12 cases a day, so we learn how to do them done quickly. And so there are devices that help you in terms of convenience. there is innovations that really look at improving the outcomes, right? And so that's when stents kind of came along. And initially we thought bare metal stents were going to be the way to go. And then that turned out to not be that good. So now everybody puts a covered stent. In terms of balloons, now we've got drug-coated balloons, which look great. Cutting balloons looked great when we started fellowship. But you know what? They didn't do anything in the end. I still use them every now and then. But also pay attention to things that are up and coming. The Fist Assist and the Amplify system, the Amplifies with Dr. Shenoy at WashU. These are both devices to help pre-dilate a vein before you make the fistula, right? So if you get a bigger vein, it makes a better fistula. So if you pre-dilate the vein, then maybe you'll get a better fistula. And then things like the Flex vessel prep that scores the balloon. It's basically a cutting balloon without the balloon. So it's little blades. A cutting balloon has blades on the outside of the balloon. The Flex device has blades just there, and you just kind of pre-treat the lesion. And they think if you pre-treat the lesion, it requires less pressure. If it requires less pressure to treat it, you're supposed to get better outcomes. And then you get into the category of things that are really creative and novel. And the first one that comes to mind is LifeSight. Who was around with LifeSights? Oh yeah, right. That was going to change the world. Not only were they a mess to put in, but they fizzled out. And I think you have to acknowledge that part of innovation is that not everything sticks around, right? But then we get into some things that are a little more contemporary. And really, in terms of dialysis access, I mean, the last 5 years has really been groundbreaking. I think people finally recognize and put importance on dialysis patients and the care that's required for them, right? And so things like the Hero graph that's been out for several years now that, again, was supposed to, change the paradigm and the algorithm, does well. They clot a lot, but they're easy to declot, so it's fine. The Innovask is a new and Humacyte are new graphs that are on the way and on the horizon, right? These are things to look out for. Vascu is in Europe, but not in the USA yet. It is an external metal frame for a surgical fistula. And so the surgeon places it around the vein, kind of secures it around the anastomosis. So it's supposed to reduce turbulence across the anastomosis. Maybe you'll get less inflow lesions, better maturation. So really impressive data out of Europe for there. The Surfacer is available here in the US. This treats central occlusion. So if a patient has moved on to the leg because everything is gone upstairs, up in the chest, well, this is basically a recanalization device. You come from the femoral approach, you come all the way up, and then you come inside out. So the Surfacer is known as the inside out technique. But it allows you to drop a catheter into the chest where someone's only stuck in the leg. And then you can convert that catheter to a Hero graft, which is basically a graft catheter hybrid. Surfacer is great. And I really wanted to get on board with the Surfacer this year, and then CMS suddenly said ASCs can't do Surfacer. I mean, I have a lot of patients that are on leg accesses and leg catheters that I could easily convert to a chest. And then endovascular fistula, and this is what I'm really going to talk about. I mean, an endovascular fistula is basically creating the fistula for dialysis without surgery, without having to cut them open, okay? And so the first question is why is an endovascular fistula more important, and why should we give it a little bit of credit? And I think the early literature shows that it's a moderate flow. So the challenge with the surgical fistula now that we've realized is that we loved them because they were great, huge vessels, right? You could see it across the room. Some of these people, you could throw a dart and you could hit it. And then we realized that these fistulas have flows of 2 to 3 liters per minute. Well, where does that all end up? That all ends up in the heart, and that's not that good in the long run. So if you can control the flow to keep it a little bit better, maybe that'll have better outcomes for the patient. They mature a little bit faster. Because of the anatomy, you can still go back and do a surgical fistula later if that goes down. The cosmetic component, we, sometimes trivialize, but when you see these pictures of what an endovascular fistula looks like versus what a surgical fistula looks like, it'll blow your mind. Operative risk obviously is much lower. Anything percutaneous is a lower risk than anything open. I can do this as an outpatient. I do this under a block. And then the shift towards value-based care. And I'm with Dallas Nephrology Associates, and we're part of the CKCC and all these value-based care model kind of pilots and trials. And the reality is all of this is going to matter in the future to everybody. It's not going to be fee for service. It's going to be, here's your, set number of dollars and do what you can with it. And an endovascular fistula cash and as an outpatient is $10,500 in our practice. And so, try getting that, everything all inclusive at a surgeon in a hospital or anywhere else. So in the long run, things like that will matter as well. Very quickly, let's go through some anatomy. As a nephrologist, before the endovascular fistulas, all I needed to know as a nephrologist was there was a cephalic vein in the forearm, there's a cephalic vein in the upper arm, there's a basilic vein in the upper arm, and then there's an artery connected to it, okay? And that's really all that you need for a surgical fistula, right? It's either a brachial artery or a radial artery, and you connect it to one of those two veins. An endovascular fistula is very similar, but what you utilize is you utilize the deep veins. And so there are deep veins, and so with each artery, there's a pair of corresponding veins. So brachial artery keeps brachial veins, radial artery has radial veins, ulnar artery has ulnar veins. There is a perforating vein that communicates the surface vessels down to the deep vessels. Okay? So if you look at the cephalic vein, for example, a surgical fistula, the surgeon just takes the cephalic vein from the surface level, swings it down to the artery at the deep level, sews it together. It's fine. But if I've got a perforating vein that connects to my deep level already and is big enough and is close enough, well, I can just make that connection there without having to cut you open. So it utilizes the natural anatomy, it utilizes the natural vein size. So everything has to line up on its own. Surgical is easy because I can move things wherever I want. Here, everything has to line up, everything has to be big enough. But when it does, well then, why do we need to go open? So if you look at, this is an ultrasound right here, and you can see that perforating vein kind of coming down. The artery's highlighted in red, but you can see next to the radial artery, there is a vein that communicates to the perforator, and that perforating vein continues all the way down to the ulnar level as well. So I can actually make an anastomosis either with the radial artery or the ulnar artery, depending on the device that I use. And so it gives me a lot of options, and because it's all at the deep level, anything that I do happens at the deep level, any failure happens at the deep level. If this doesn't work, they can still go back and get a surgical brachiocephalic fistula. No big deal. So my surgeons are happy, kind of. The ones that like me are happy. So there's two devices for endovascular fistula. One is the ellipsis catheter. So this one uses the proximal radial artery and connects it directly to the perforating vein. And this one is basically just a kind of a clamp. You see the catheters open and then you're going to close it. And what you do is you get that tip into the artery and the rest of it in the vein. And you do this all under ultrasound, and you do this with a needle and a wire. Let's go back to what is IN. Right? So if you look at their animation here, you're basically going to, anybody do a radial artery stick? Yeah, all the time, part of fellowship, part of residency. We do it at the wrist. All this is a radial artery stick at the elbow. But I'm going to go through the vein on the way. So we come into the skin, we're going to stick the vein, and then we come down the vein, and we stick the artery. It's not that hard. Do it all under ultrasound. Drop a wire, drop a sheath. Anybody lost yet? Anybody that's done medicine can follow me so far. Right? That's it. Then the device goes in, put the tip in the artery, close it, activate it. It's a 10-second cycle or so, 30-second cycle. And that's it. It uses heat to create the anastomosis. It fuses the artery and the vein together. Procedure time is 10 to 12 minutes for a dialysis fistula. That's it. Do a little angioplasty at the end. Dilate up the anastomosis a little bit more. The other device is a wavelength. This is a dual catheter device. One, the venous, there's two electrodes. One goes in the vein, one goes in the artery. And the one on top is the active electrode, and it sits in the vein. The creator for the wavelength device, I believe was a cardiothoracic surgeon. And he says, I deal with these traumatic AV fistula all the time, stab wounds, gunshot wounds. Those never shut down. I have to go take these patients to the operating room to shut down a traumatic fistula. So why is it you guys can't make a dialysis fistula that stays open? So his device is basically a controlled traumatic fistula. So this has two magnetic catheters, and the magnets are really just for alignment. All the fun is in that electrode, and it sits up against the backstop. So you get the arterial catheter in the artery, you get venous catheter in the vein, and again, ultrasound. This uses fluoro as well. Once they're lined up, and this you can do on the ulnar side or on the radial side. Once these are lined up, and you use the magnets to help align, well then this is just basically an internal bovie. Hit the button, 0.7 seconds, activates, makes a cut between the vein into the artery. And so here you take the wire out, everything lines up. They're going to show you this little blue light. There's your cut. And this is not kind of a heat fusion. This is just a double slit anastomosis. This is a controlled traumatic fistula. What happens is over the next 2 to 3 weeks, it endothelializes the communication between the two. Take it out, you're done. Procedure time here, because you're using fluoro as well, 20, 25 minutes. Okay? So it is very impressive in terms of what can be done. It's very easy to do. Skills that, as interventional nephrologists, we already have. And I have a good friend of mine who's a renowned vascular surgeon in Dallas, and he does these as well, the wavelength. But he always says, look, the endo-AVFs is going to end up in the hands of nephrologists. There's nobody as skilled as a nephrologist to do this, and there's nobody understands dialysis well enough to do this. I can do this, but it's going to stay in their hands. That's where it'll always stay. So now here's the thing. The endo-AVFs, low flow, multiple outflows, because if you think back at my little sketch, there's deep venous flow and there's superficial venous flow. Okay? So it's divided between multiple vessels. So when you look at the arm, it's not quite what we're used to seeing. And so if you look at this arm, I'll ask you, is there a mature fistula there? No. Is there anything there? I mean, it looks completely normal, right? This patient is one of my favorite patients, actually. He and his wife are both in healthcare. So young, upper 40s. So they know what dialysis means. He was not on dialysis at the time. So they kind of knew what to expect. And so I looked at this arm and I said, yep, you're ready. He said, what do you mean I'm ready? I said, yeah, your fistula's ready to go. He says, how? I've seen a fistula. His wife's an ER nurse. She knows fistulas. I said, let me show you. So if you look at, in the antecubital fossa, his cephalic vein is 7 millimeters in diameter. His median cubital vein is 5 millimeters in diameter, both big enough to cannulate. His brachial artery flows are 708 to 850 milliliters per minute, which is all I need for dialysis access. We're running him at 400. Why do I need a little buffer over 400. So 750, 800, perfect. I was like, yeah, you're done, you're ready to go. He says, you've got to be kidding me. Nope. You should have seen the smiles on their faces when they realize they have a dialysis access and nobody will know, that he's going to walk around in short sleeves and nobody will know. I mean, that's why I say patients are the ones that are going to drive this, right? That he can say, nobody has to know anything. So 6 months later, he finally started, or 4 months later, he started on dialysis, sat there unused, untouched. Now he's 7 millimeters both. Got started with 2 beautiful buttonholes, right? He went straight to home dialysis from the clinic. And, he's 2 years out now. He started 2.5. He started just before COVID. His buttonholes look great, and they are ecstatic, Imagine walking around and this is all you see. And at a quick glance, nobody thinks of anything, maybe a little pimple or something. If you don't know what a buttonhole, if you don't know dialysis, this is it, right? And he's not my exception. These are all mature fistulae. These are all waiting to be used. These are all more than 6 months out, ready to go. The top right, the patient was pre-dialysis for 6 months, got on dialysis for 6 months, and then had a transplant, and that was a year after his transplant, right? I mean, his arm doesn't even look used compared to the others. So does cosmesis matter? Absolutely, right? My young patients come to me, even if they have, the standard thought is if they have a forearm radiocephalic option, we go with that first. And then I say, 5 years, come back and I'll do the endo in the upper arm. My patients that are in their 30s, no way. No way you're cutting on me. And, they're savvy. They've done their research. They know what dialysis means, and they know what dialysis looks like. And they refuse to get a radiocephalic even if they have it. They say, this is what I'm doing. Okay. So my young patients insist on this. The elderly patients, my octogenarians, that are 85. I've got several 88, 89-year-olds, they're like, I don't want to be cut on at this age. I wouldn't either. So even if they do have a radiocephalic option, most of them choose for this as well, because at that age, how long are they going to be on dialysis? How many accesses do I need? The whole thought is, okay, this will burn, and then we go save veins for the next one. But at 89, how many accesses do I need in a patient? Give me one good one, and that'll last them. So it's a very bimodal distribution in my practice. The very young patients choose this. The very old patients choose this. And around 40, 45 is when people wise up. When I say, look, I could do this, but you're probably better with a radiocephalic, and we'll do this next time. They say, okay, yeah, that's fine. They get it, right? The trick is still getting the dialysis clinics to stick it. And the thing is because obviously you can't see it, so how am I supposed to stick what I can't see? And so the instinct is, if it's not there, it must be deep. But in reality, it's actually much more superficial. The other part of it is that the cannulation is actually all into the cubital fossa, not so much into the upper arm that we're used to. And the way I try to think about it is if I remind people that a surgical anastomosis is here, so we're cannulating here, right, just a couple of inches above it. An endoanastomosis is below the elbow, so we cannulate right into the elbow crease, right? If I try to cannulate upper arm like I do a surgical fistula, it's like taking a surgical fistula and saying, hey, stick it in the shoulder. So when I'm at the clinics, I'm like, hey, you want to stick this fistula here? They're like, you're nuts. I'm like, okay, then don't stick my fistula where you want to stick it. You're nuts, right? You have to go into the cubital fossa. And so really when you look at cannulation, that's where it is. It's all into the elbow crease or just above it. And, the concerns about the needles being so close, the concerns about into the elbow crease and them not, being able to move their arm. Yeah, I had them all. But, I've been doing this for 3.5 years and it's fine. If the patients make do. They understand what getting this means and they're fine. And so, if there is a dual outflow, because that perforator sometimes connects to both median cubital and cephalic, then I put a needle in each vessel. If there's a cephalic outflow, then easy cephalic vein cannulation. If there's a basilic, a median cubital outflow, these patients are the ones that ended up with a brachiobasilic fistula surgically. Big incision, because that basilic vein you have to mobilize and bring up to the front. Well, that median cubital vein gives you some extra real estate you didn't have. So the overwhelming majority of my basilics are not getting transposed or not getting mobilized. So I just stick the median cubital vein. And so that becomes the other benefit, that who's going to mobilize a 425-pounder with a basilic vein, and it happened. One of my patients, his first access was a graft. He kept on clotting. And then I said, what's going on? And he said, so we finally did a hypercoag workup. Turns out he's positive. We do it all the time, but this guy was actually, positive. So we got him on Eliquis. He's been doing fine. So then I look at his arms, and he's got great basilic veins. And I said, well, why didn't the surgeon do a basilic fistula? Well, because he's got big arms. But if you look at under ultrasound, the median cubital vein is, fantastic. The yellow line is the 5-millimeter depth line. So you've got enough room to get 2 needles across that median cubital vein the majority of the time. And so then as that median cubital dives down on the ultrasound, that's when it hooks up into the basilic vein. So if I can utilize this little runway to get both of my needles in, then these patients that would have gotten a brachiobasilic transposition now end up with no surgical whatever, right? And so these are all of my brachiobasilics, or endobasilics, actually. So you can see both needles in the median cubital vein. I love buttonholes. Most of my patients are buttonholes, right? Oh, and then there's that whole argument, the infection rate with buttonholes and this and that. And that's why I fell out of favor. In Dallas, yeah, I know, I feel the same way. I saw the look. It's funny because even my partners gave me I got a little pushback every now and then. You can't do buttonholes. Why not? Well, the infection rate's so high. Well, even before endofistulas, the home patient population in Dallas is 100% buttonhole. I said, tell me about the infection rate in our home population. Oh, well, that's 0. So it's not the infection rate is so high. It's clearly the home patients are doing something the clinics were not, right? Which was being a little more diligent with their sterilization. and their sterile technique. And so once you get them on board and realize that look, all the home patients are buttonholes and they do fine, and we have 0 infections, all the infections are in the clinic. It's not the buttonhole that's the problem. It's the person accessing the buttonhole that's the problem. So all of these buttonholes, but all of these patients, all of these arms, if they got a surgical access, it would be a big brachial transposition. And I think that's really one of the great innovations here with the endofistula, is not just that, is not that it spares people from a small incision for the anastomosis. You can spare someone from a big incision from a big basilic transposition. All right, very quickly, this is academic institution, so I have to do a little bit of literature. This was, my journal club days, reading the article in the elevator on the way up to the department. Two pivotal trials. One was for the ellipsis, one was for the wavelength. Both of them came out around 2017, 2018. So we're 5 years out now, right? And, a lot of people still don't know what an endofistula is. A lot of nephrologists still don't know what an endofistula is. A lot of them don't see it in their practice still. And so you look at, the thoughts of 5 years later, what are we supposed to say? Or what are we supposed to look at in terms of success? And can we compare it to a surgical fistula? No, not at all, not yet. Because part of it is the anatomy is completely, the ulnar anastomosis, no surgeon will go there. Maybe a radial anastomosis you can compare. Do we compare ellipsis to wavelength? Not the time. We're still getting it started. Maybe one day, but now's not the time. Or do we really look at newer publications to see how they compared to the original FDA trials, right? Because is it really that good in the real world? And trying to figure out what matters for a successful endo-AVF, patient and fistula. And I'm going to spoil it. The answer to the last one is I still don't know. I can look at a vessel mapping and say, oh, you're going to do great, and they fail. And I can look at one and say, you're going to be marginal, but if you want to try it, I will, but we're probably going to need surgery, and, they're okay with that. And I'll tell you, those things just take off. So, we look at vessel criteria as our, guidelines that, yeah, this is a great candidate, but, sometimes I don't know. There have been multiple papers that have been out. But you can see the volumes are all still pretty low, and I'm not going to bore you with all of them. The first wavelength paper up top with Zavella is actually Dr. Alvarez is one of the co-authors. So, again, when I talk about leaders in interventional nephrology, and the legacy Dr. Martin puts behind. But you can see several papers have come out, 90-day physiological maturation. They seem to match pretty well with the original papers. Cumulative patency, actually pretty good across most of the papers. And, we're looking at from the pilot studies of 85% patency at 1 year. What surgeon can boast that? So, but that was very selective criteria. You're not doing it on everybody. If they want me to, I can try it, right? All bleeding stops eventually. But tube needle cannulation, oh, that was all over the place, right? Communities, smaller communities that have a single or a few dialysis clinics can do well because it's the experience that the centers need. Once they see enough, they say, okay, I get it, I can do it now. But I'm in Dallas, where I've got 125 plus dialysis clinics, and I still have patients that have never seen one of these. I've got one next week who's cannulating, and they have never seen one of these. And that becomes a challenge, is that sometimes every patient is the first patient in the clinic still for a 3-year-old program. And so this is where, failure for endo-AVF is going to boil down to two things. One is going to be cannulation, or the second is going to be reimbursement, unfortunately, because reimbursement's still all over the place and hasn't quite been. It's sufficient, but I know a few programs that had to stop because of that. Okay, last picture. This patient, I did his fistula before he was dialysis. We have a very aggressive transplant program, or 4 actually in our city. And so he ended up getting a living related kidney before he ever needed dialysis. So fantastic, right? He's got an access. It looks beautiful. And he never needs dialysis. And so I see everybody, once their access is mature, I see him every 6 months for a follow-up, just to make sure. So my center called him for a follow-up visit. He freaks out. He shows up, and he's like, Dr. Mawla. I'm like, what's wrong? He's He's like, I forgot about the appointment. I'm like, that's okay. I'm like, you got a kidney, it's fine. Like, what's wrong? He's like, I haven't checked my access. I don't know if it's still good or not. He's like, I completely forgot I had a fistula until you called me yesterday for my reminder. Okay, let's take a look. Because when he was before his transplant, he was very diligent. I told him what to look for. He used to examine it once a week, right? Since he got his kidney, he's no longer a dialysis. He's no longer a kidney patient. He's no longer a dialysis patient. He doesn't need a fistula. He forgets he has it. He didn't look down and that's his left arm. He doesn't look at it all the time. He looks at it every day. He's like, I forgot I had the fistula. So I said, okay, let's scan it. Scan looks beautiful, just like always. But that's where I kind of, where we said, look, it's there when you need it, but it's forgotten when you don't. And I think that's really one of the beauties of the endovascular fistula.
It's my honor to introduce our next speaker, Dr. David Bushinsky, who's joining us from Rochester University, where he is the John J. Cooper Distinguished Professor of Medicine Emeritus. Dr. Bushinsky went to medical school at Tufts University, where he continued for his residency and fellowship in nephrology, and then was on the faculty as an instructor. He moved to the University of Chicago and was there for 9 years, and was recruited to the University of Rochester in 1989, actually simultaneously with Dr. Martin, and he became the director of nephrology at the University of Rochester at that time. And I know that Dr. Bushinsky doesn't remember this, but he had an impact on me as a medical student. So I was a third-year medical student at the University of Chicago, and I remember vividly, I was doing my clerkship on the urology rotation. And, and we had, we had got a renal consult. And who should be the consultant? Dr. Bushinsky. And I, as a third-year student, was struck by his ability to definitively talk about these fluid and electrolyte problems that completely befuddled my immediate mentors. And it was one of those instances, and I'm sure many of us have had, where I came to myself and thought, I should think about being a nephrologist. I was inspired by your consult to us urologists, yes, at the time. But anyway, thank you for that. And Dr. Bushinsky spent his career investigating nephrolithiasis, metabolic bone disease, acid-base abnormalities, and clearly his work has intersected many times with that of Dr. Martin. He's authored over 180 peer-reviewed reports and is widely sought after as a speaker. So we are honored to have him with us today. Dr. Bushinsky.
Thank you for that lovely introduction. I don't remember you as a student. I'm sorry. But I want to thank the organizers for inviting me to this wonderful event honoring Kevin. And before I launch into a discussion on stones and bones, I really have to say a few words about Kevin. Dr. Kevin Martin exhibits all the qualities of an outstanding triple threat. He's a productive and innovative scientist, an active clinician, and a consummate educator. Kevin trained with luminaries in the field of mineral metabolism, and then went on to independently work on basic studies, including isolated perfused bone and cell cultures of the osteoblastic line UMR106. He made fundamental discoveries on the regulators of PTH secretion, including the effects of acidosis on PTH release and binding. I think Kevin's love of clinical medicine drove these studies to help patients. He regularly studied and wrote in hundreds of publications, the goal not only understanding this complex topic of mineral metabolism, but educating all of us. His NephSep chapters are a model of intellectual clarity. Kevin knew that if you understood the relevant physiology, you could best understand what's going on with your patient. His talks are elegant. His slides are a model of how PowerPoint should be used. Listening to his talks, I marveled at his clear exposition of the multiple interacting factors that control calcium, phosphorus, PTH, vitamin D. And for just a moment, I thought I understood it. Over the years, Kevin became the real expert on PTH. When few understood the differences in PTH assays, Kevin educated us onto the differences in binding sites, antibodies, results. He helped usher in the calciumimetics, first cinacalcet, then etocalcetide. And that he started from the very beginning, ground zero rat studies. He was instrumental in the rigorous comparison of these agents that have helped patients around the world. On a more personal note, Kevin has not only been a colleague, but a close personal friend. We became division chiefs at about the same time, as all hospitals and health systems want the same thing, more productivity with less support. We shared approaches as to what worked and what didn't. I don't think Kevin really realized how important he was and what a valued resource he was to me. Lastly, and perhaps most importantly, I have to thank Kevin for membership in an august society that I never dreamed I'd be worthy of. We were sitting in a lounge in an airport in Buenos Aires, Argentina, waiting to catch a very early morning flight to another meeting in Iguazu Falls, Brazil. Kevin suggested a beer, as it was clearly afternoon in Dublin, and I agreed. With that early morning beer, I qualified for membership in the Irish Drinking Society. Somehow, Kevin had never made it to my CV. Kevin, I'm so pleased to be part of this celebration honoring your multiple contributions to nephrology. Now let's get on to stones and bones. My disclosures. So let's think about kidney stones. And let's start out with a patient, but let's start out with 1,000 patients. 750 males, 250 females, age of about 35. Each of these patients has formed about 8 stones, meaning they formed up 1 stone a year because there's about 100 stones per 100 patient years. These patients have had cystoscopies, hospitalizations. It's interfered with their lives. Keep that in mind as we talk about this. If we talk about the prevalence of kidney stones, we see that over the decades, the number of kidney stones has increased. The darkest are men, women, and overall. That increase is clearly not genetics. That increase is diet, is fluid, it's lifestyle. It tells us there are things we can treat. And so if we treat our patients properly, we can bring down the prevalence of kidney stones. Now, is this a big problem? Yes. In Haynes data, males over 60, almost 18% have stones, and women, only 10%, but the women are rapidly catching up. If we talk about the type of kidney stones, we see that most are calcium oxalate and calcium phosphate, some calcium oxalate alone, some calcium phosphate. Uric acid stones, where uric acid often forms a nidus for calcium oxalate. Cystine stones, very few, but everybody should be checked sometime in their life if they have stones for cystine. And infection stones, almost a quarter of the stones. We'll talk about today calcium-containing stones, since that's about 70% of stones. If we look at diseases associated with stones, 7% have primary hyperparathyroidism. That's a huge number. Our endocrine surgeons love our stone clinic. Keep that in mind when you see a stone patient. Idiopathic hypercalciuria, 1/3 of our patients. That is the most common disease. We don't know why the patients have hypercalciuria, but they do have hypercalciuria. And as you can see, we can clearly treat it. Hyperuricemia, 1/4 of the patients, and so on. 1/3 of the patients are clearly idiopathic, but again, we can treat these patients. Idiopathic hypercalciuria, 1/3 of the patients, there's a genetic basis for this disorder. It's more common in relatives. Relatives of calcium stone formers have exaggerated calciuretic response to an oral calcium challenge, and there's clear familial occurrence. To understand kidney stones, you have to understand urinary saturation. In an undersaturated urine, the components of a stone are so far apart, they'll never come together. At the equilibrium solubility product, those ions will be in equilibrium with the solid phase, which will neither grow nor shrink. Metastable urine, the calcium and oxalate, for example, are so close that they'll actually form on another substance. At the formation product, they'll form on their own. In an unstable urine, they'll just precipitate out. If we look at it, we have increasing saturation, increasing probability for stone formation. So our basis for treatment is to move up on the scale from a metastable urine, for example, towards an undersaturated urine. To understand stones, calcium stones, you have to understand calcium, homeostasis. We absorb about 4 millimoles of calcium a day, 160 milligrams, very small extracellular space. On a daily basis, there's bone formation and bone resorption, which should be absolutely equal in non-growing, non-pregnant, non-osteoporotic people. We filter a lot of calcium, reabsorb the vast majority, and through the marvels of integrative physiology, calcium absorption absolutely equals calcium excretion. So with that in mind, we and others thought about alternate mechanisms of hypercalciuria. We could absorb too much in the intestine, we could have decreased mineral reabsorption, we could have enhanced bone demineralization. Lots of grants were written by lots of people, including myself, on this. And then there was data, this is from Amy Liswitz-Strauss from Frederick Koh's lab, which said that if you put people on a low calcium diet, in this case 2 mg per kilogram a day, you see that urine calcium in the normals is lower than in the patients with idiopathic hypercalciuria. But look at calcium balance. The people on the left, the normals are in positive balance, but the patients go from positive balance above the line to negative balance. What does that mean? Those in positive balance are absorbing too much. Those in negative balance have so-called renal calcium leak, but there's a clear continuum. There are no pockets for isolated physiology. And we see that on some days a patient might be above the line, and other days a patient is below the line. What this taught us is you should not try to separate the patients. And if you do try, and you're wrong, which you will be most of the time, and you put them on a low calcium diet, if you think they absorb too much, the consequences will be severe bone demineralization, a disaster. So how do humans form kidney stones? Back years ago, 1937, Randall found plaques in the intersection between the kidney and the urinary space. 3 papers, largely forgotten. Over the years, people have argued that stones would form in the collecting tubule, that there were differences in charges that would allow stones to form, and other people argued that the flow was too high. But about 20 years ago, Andy Evan from IU, working with Jim Lingaman, Fred Coe, and others, found that the initial site of stone formation was around the thin limb of Henley's group, A in that picture. It extended, it extended, it extended, and it eroded through into the urinary space, forming the Randall's plaque, which had been known 50 years before, but absolutely forgotten. And then through a process of heterogeneous nucleation, a calcium oxalate would form on that calcium phosphate. And once that stone broke off, it would obstruct the ureter and you would have clinical stone disease. But it also tells us, if you keep the urinary supersaturation low, that calcium oxalate will not grow, the stone will not become clinically significant, the basis of our treatment. Now, I said we're going to talk about bone, so what about bone and stone formers? This is from Sakai from UT Southwestern. Report looked at the literature about 10 years ago and found bone disease, found decreased bone mineral density in stone formers. 40% of stone formers have decreased vertebral spine density, 31% decreased hip density, 65 decreased radius density. Melton looked at what happened in Olmsted County, which is Mayo Clinic, and they looked at the expected hip fractures or vertebral fractures versus the observed. And you can see, it doesn't take a statistician to see observed is much higher than expected. Our patients are fracturing. This is from Eric Taylor and shows that wrist fractures are higher in men and women if they're a stone former, not hip fractures in their studies. And then Michelle Denberg did a beautiful study, and she showed that on the right is women, on the left is men. The solid line is stone formers, the dashed line is no hieroglyphiasis. 500,000 patients, clearly more fractures, especially in the women, in stone formers compared to non-stone formers. So it's not only kidney stones, we have a bone disease. So we wanted to study this. And how do you study stones and bones? Well, we developed a genetic model, the genetic hypercalciuric stone-forming rats. And in this model, which is now up to 125 generations, you see that in the first 30 or so generations, there was a nice increase in urine calcium excretion, which didn't change in the controls. Our genetics people tell us there's 7 to 9 genes involved. We explored this extensively. The NIH paid for a lot of it, and we could never isolate a specific genetic abnormalities. But let's think about the physiology of how these rats were hypercalciuric, because we're studying a model of the most common urinary disease causing stones, idiopathic hypercalciuria. We see that intestinal calcium transport is much higher in the hypercalciuric rats than in controls. The left are the controls, the white is the absorptive flux, the yellow is the secretory flux, the net flux is in light blue. You see in the hypercalciuric rats, it's much higher in the boys and in the girls. We also see that if we perfuse the kidneys of the hypercalciuric rats, take out their parathyroid glands, urine calcium excretion is much higher in the hypercalciuric rats than in controls. And in this slide, which is the one slide that has not been published and all that I'm going to talk about, we've isolated the defect to the thick ascending limb of Henle's loop, where there's far less calcium transport in the hypercalciuric rats than in the controls. Hopefully JCI will like it. So what have we learned? We've learned that this calcium homeostasis in the hypercalciuric rat has increased urine calcium excretion, decreased calcium reabsorption, increased calcium absorption. What about stone formation? Well, in the control rats, there's no kidney stones. In the hypercalciuric rats, by 18 weeks, they form stones. And if we look at the control rats, they form apatite stones, just like Randall's plaque. And if we add a precursor to oxalate, which is hydroxyproline, they form calcium oxalate stones. So we now have a model of calcium phosphate stones and calcium oxalate stones. And this is a scanning EM of the calcium oxalate stones that the hypercalciuric rats form. So what have we learned now? We've learned that the rats form stones. What about their bones? Well, more recently, we started looking at their bones, and you can see that bone mineral density in the hypercalciuric rats on the right is far lower than in the control Sprague Dahlia rats. If we look at their osteoclasts, which are the bone resorbing cells, you don't have to be a pathologist to see that the osteoclasts are bigger and more numerous in the hypercalciuric rats on the right compared to the control rats on the left. If we look at the osteoblasts, the bone-forming cells, they're lower in the hypercalciuric rats on the right, using 2 different ways of making osteoblasts, than in the control rats. So what are we learning? Bone resorption is higher, bone formation is lower, bone density is down. So the hypercalciuric rats have a systemic defect in calcium transport at all the major calcium transporting sites, and there's amazing parallels to humans. If we look at humans, they absorb too much calcium, they resorb not enough calcium, and they have decreased bone mineral density. So it's a reasonable model. So most of you are wondering why this could occur, or at least I did. The number of receptors for vitamin D in our hypercalciuric rats, both on the bone shown here, the intestine, and the kidney, is upregulated, and there's a whole series of studies, which we're not going to talk about today, on how these vitamin D receptors are biologically active, cause increased calcium transport, increased bone resorption, and decreased renal tubular calcium reabsorption. So most of you see patients and not rats. So let's talk about our patients. First thing a patient comes to stone clinic, because we have a big stone clinic, and says, "Doc, I formed one kidney stone. What happens if I do nothing? I'm 35 years old. I formed one stone in my life. What happens if I do nothing?" And the data is all over the place, but we tell them about 50% of you will form another stone in 5 or 6 years, to which some of them say, "I'm out of here." But to the others, we say, just be evaluated. Let us do a basic evaluation. We take a nice history. Physical exam isn't really very useful. We carefully check calcium, phosphorus, PTH, vitamin D, and TSH because of the high incidence of parathyroid hormone disease. And what we don't do is x-rays. The number of young women who come into our stone clinic who've had CT after CT after CT directed right at their ovaries is mind-boggling. Ultrasound is pretty sensitive, not that specific, but good enough. There is study after study showing that it doesn't miss anything important, and there's no radiation exposure. If you learned one thing this morning, get an ultrasound first in your stone patients. Don't do a CT. Even low-dose CT is a pretty high radiation exposure. MRI is perfect, but it would bankrupt our healthcare system. Think about ultrasonography for your stone patients. So how do you prevent stones? Direct your treatment at what's causing increased urinary concentration of the substances forming stones. This isn't rocket science. This is 8th grade chemistry. If they have small urine volumes, increase the urine volume. If their diet is ridiculously high in oxalate, talk to them about decreasing the oxalate. If it's high in calcium, we'll talk about using thiazide diuretics or potassium citrate. High uric acid, we as Americans tend to eat too much. High protein foods animal proteins generate acids, cause hypercalciuria. Those high animal proteins lower the citrate because of the acidic urine, increase the citrate. Low potassium because the anion that goes with potassium, and magnesium is a wonderful inhibitor of all crystallization. So what do? We tell our patients to drink a lot of water. Dilute those substances, lower the supersaturation. We tell them to eat about 1 gram of calcium a day. If you eat too little calcium, you'll absorb the oxalate because in the intestine, the calcium and oxalate bind. If you eat too much calcium, you'll absorb too much calcium. So it's a nice U-shaped curve, just like most other things in medicine, about 1 gram a day. Stay away from sodium. More sodium in the diet, equals more calcium in the urine. It's a 1-to-1 ionic excretion. And meat proteins moderate so you don't generate an acid urine. This is very standard stone clinic stuff. Reduces stone formation probably by about 60%. because it's basically 8th grade chemistry. But how about when we get into pharmacologic treatment? Thiazides or potassium citrate are the mainstay. Think about it. Thiazides have a positive effect by decreasing urine calcium excretion. There's clear data that I'll show you that thiazides increase bone formation. Alkali, we've shown in vitro numerous times that bone formation is increased with alkali. Alkali decreases the acidity of the renal tubule, increased calcium reabsorption, lower urine calcium excretion. So thiazides and alkali, alone or together, might have a positive effect not only on kidney stones, but on bones. So the data on thiazides, the first studies were in the 80s, and it clearly showed hydrochlorothiazide and chlorthalidone far better than placebo. In the most recent meta-analysis, again, thiazide is favored for prevention of recurrent kidney stones. Best data we have. What about bone? This data that thiazides reduce hip fractures are mostly done in people who thiazides were used for hypertension. I sort of have the feeling that if thiazides didn't cost about 2 cents a day and drug companies can't make any money on that, would be a really reasonable treatment for osteoporosis, but it'll never really be studied because of our reimbursement systems. But thiazides clearly decrease the risk of hip fracture. Potassium citrate, our other mainstay of therapy. Again, the meta-analysis, potassium citrate decreases stone formation. Potassium citrate in bone, this is a great study that a lot of people don't know about. Journal of Clinical Endocrinology and Metabolism, somehow, I lost there it is, the reference. 200 patients, half given K-citrate in red. Potassium citrate goes on to form bicarbonate. It's a base. It neutralizes systemic acids versus placebo. They analyzed 85 and 84 citrate and placebo, respectively. 2-year study. What did they find? In the red is potassium citrate. In the blue is placebo. Both at the L2 to 4, femoral neck, total hip, total body. Those patients given potassium citrate clearly had increased bone density compared to those patients given placebo. To me, a very powerful study. It's been replicated by others. But again, if we have thiazides and citrate, we can favorably affect bone. But how about the combination? Unfortunately, we don't have clinical studies on the combination of thiazides and potassium citrate. So let's turn to our model, which is our hypercalciuric rats. And we gave them either potassium chloride as a control, potassium citrate, potassium chloride, and chlorthalidone, and the fourth group was potassium citrate and chlorthalidone. So everyone got an equal amount of potassium. Some got citrate, some had chlorthalidone, some had the combination. 18 weeks later, we looked at everything. I won't show you all the data, but it's very clear, it's really cute. Urine calcium with potassium citrate goes down in green. With chlorthalidone in red, it goes down further. And with the combination, it goes down even more. We've measured everything to calculate supersaturation, and it goes the way you would think it would. But what's important is calcification, kidney stones. You see that? Potassium chloride is the control. Potassium citrate didn't do anything. Potassium chloride plus chlorthalidone, which is really chlorthalidone, virtually or totally eliminated stone formation, and the combination was a little worse than chlorthalidone. What about the bone? Upper left, bone volume to total volume clearly went up with chlorthalidone. The combination of chlorthalidone and K-citrate, about the same. Trabecular thickness went up with chlorthalidone, so the trabecular are thicker, the number is greater, the separation is less. Chlorthalidone induced better bone. And when we published this 3 years ago now, in rats who formed calcium phosphate stones, right? This is the Randall's plaque. The chlorthalidone alone is superior to potassium citrate alone or in combination in reducing stone formation and improving bone quality. But most of our patients have calcium oxalate stones. So we essentially repeated the same study, but added some hydroxyproline to it, so all rats form calcium oxalate stones. This we published last year, and the data is pretty clear. The combination of potassium citrate and chlorthalidone lowered stone formation or calcification better than either agent alone. Thiazides, chlorthalidone, improved the bone, and chlorthalidone plus thiazides didn't do anything. And the conclusion in this one is in our hypercalciuric rats, fed a diet that results in calcium oxalate stone formation, the combination of citrate and chlorthalidone prevented stone formation better than either agent alone. Chlorthalidone is best for bones. The citrate didn't help. So the caveat, of course, is these are rat data. We don't have any human data. But if this rat data can be shown to apply to humans, for calcium phosphate stones, use chlorthalidone alone. For calcium oxalate stones, use the combination. I'm hoping someone will do this trial. So let's get back to our patients. 1,000 patients, 750 men, 250 women. I showed you how they didn't do well. They were forming a stone a year. It was interfering with their lives. They have a concert musician. It interfered with his concerts. Students couldn't take exams. What we talked about today, the basic treatments of fluids, calcium, thiazides when needed, followed them for another over 3 years. The stones per 100 patient years went down to about 8, and about 89% didn't form another stone. Taking care of kidney stone patients is one of the most gratifying things you can do, because they walk into your office and they show you pictures of their kids, and they're just living their life. They have nothing to talk about because they're doing well. And as nephrologists, the other patients I see, they can't say that. Very gratifying. I just have to thank all the people that I've worked with over the years for doing this. Fred Coe, Murray Favis, and I started doing this a long time ago. John Aspwin, Ty Nakagawa have measured all the supersaturations. Mark Runpass, all the bone work. Andy Evan did a lot of renal pathology, which I didn't show you. A lot of genetic work with Rod Thacker in Oxford. At Rochester, a whole host of people, but mostly Nancy Krieger, my close collaborator, for many, many years. And with that, I thank you.
All right, well, that was absolutely fabulous talk. We're going to go ahead and move along in our program. And as Dr. Edwards emphasized at the start of our program, one of our points of celebration today is the recent graduation of our 100th fellow. So I'm delighted to welcome Dr. Mai Vo and Dr. Marie Philipneri, who are going to share a bit about the accomplishments of our fellowship program and then honor our recent graduates. Yeah.
Well, thank you, Dr. Lentine. On behalf of the fellows, I would like to welcome you to this celebration today in the honor of Dr. Martin and our 100 fellows. As you know, this our first fellow graduated in 1911, and we have a 111 fellow currently in our class, so which is great. And I happen to be the 22nd fellow, and after 22 years, I'm still struggling to get out of St. Louis. Our fellows have come from many states across the country and over 25 countries across many continents. I don't want to go through the whole list right now, but we do have a wonderful list of all fellows here on the poster, and Dr. Lentine presented earlier. They are all a wonderful group of colleagues who are good-looking, smart, and gone on to do many wonderful things. They have excelled in clinical nephrology, interventional, critical care, transplant nephrology, and in many, many fields. A lot of fellows have gone on to do research, many leadership roles, community engagement, and many great things. This will not be possible without the tremendous sacrifice of our 111 fellows, and this movement will not be possible today. So I truly appreciate everything you have done to get through the fellowship, which is not easy, as you know. Another question that comes up is, why in the world would you do nephrology? As others who are not nephrologists, the simple answer is we like letters, numbers, channels, arrows, and complexity. In a nutshell, we are kind of a nerdy bunch. And many of the fellows who graduated through the program have had kids, and I was the first one to have my first one, and have had two more. So all these little nephrons running around deserve the badges as well. I want to recognize Dr. Martin, who started the program and led the program for many years. And I would blame you and Esther for having me here. And our tremendous faculty who have taught us over the years. Thank you, Dr. Bastani, Dr. Edwards, Dr. Lentine, and many others. Dr. Bastani, I should point out that I quickly learned that I have to come up with my lunch, supper, and even midnight snack, just in case I need it. Thankfully, the duty hours saved us and Dr. Bastani. And I want to thank everyone, all the staff and patients who have influenced my life, as well as all of our fellows today. And thank our families who have put up with us and walked us through the years. And we should support of department, the GME, the School of Medicine, and many others within SLU and outside of SLU for walking us across this path. We are a party bunch, as you saw. We missed the karaoke during the COVID. Can't wait to get out and party again. So in closing, I wish to thank everyone and congratulate the fellows and wish you well in your careers, and hopefully we'll have more of these get-togethers in the future. Thank you.
I am so glad we met up and said she can talk first, because I think I'm just going to echo everything that Dr. Philipneri has said. Thank you so much. So I'm Mai. I'm one of the products of this place. I did my residency here at SLU and fellowship thereafter. And then I've been an attending here for 8 years. So we just finished interviewing a bunch of people for nephrology fellowship, and one of the things I always say is, hi, I'm Mai. I'm a product of this program. So I think that speaks volumes about our program. And you know, today's about Dr. Martin, and so even if it wasn't about Dr. Martin, I would have to bring up Dr. Martin, because I know when I first met Dr. Martin, he was only doing interventions. And then one July, I guess we were low on staff, they decided to put him on Gold Team. And for anybody who knows what Gold Team is, it's a golden place, yeah, for us to do our, you know, consults and stuff like that. But it was a primary nephrology service. Residents were afraid of it. But here comes Dr. Martin walking in, first day July, and I'm my first day as a resident. I was an intern. I turned into a resident the next day, July 1. And I'm like, oh man, I'm so scared. He's a lot older than me. But, and at that time I didn't know much. I knew I wanted to do nephrology, but I was so into medicine that I didn't pay attention who was important in nephrology. And I'm glad I didn't, because I didn't really know who Dr. Martin was. And we started, rounding, talking and everything. And I realized, how nice this man is and how easygoing he is and how, it's so easy just to say whatever I want to say without him really judging me. And I think that's one of the things, again, I'm a product of this program because he's been so wonderful and nice. And one of the things that I've learned now, being program director, just the way to be is, leading by example. And I've learned that so much from Dr. Martin, as well as so many other people. Dr. Philipneri has mentioned, Dr. Edwards, Mastani. And I love how people always ask me, why don't you call him Kevin? I'm like, he's never going to be Kevin to me. Or Bahar. We say Bahar. At home, I'll be like, yeah, I was rounding with Bahar today. But in all jokes aside, again, a couple highlights in my career are, as some of you know, I'm an interventional nephrologist. Why did I stay at SLU? It's because I've always felt welcome. I always felt like I could be myself. For anybody who can already see, I'm wearing a green suit, so I'm pretty loud. I remember one of the first declots we did together, when he let me actually use all the wires and the stents and all that stuff, the patient started flowing again, and I remember I did a dance. And Dr. Martin, instead of looking at me kind of weird, he danced with me. And I was like, oh my God, I'm going to stay here for the rest of my life. And so for my career, my life as a nephrologist, I have stayed here for this long. And again, thank you to Dr. Martin. I feel so blessed that he somehow convinced me to be program director. And I remember saying to him, I'm going to do it for 1 year. 1 year only. So I'm on my 4th year now, so I don't know what happened. Dr. Philipneri, there's something that's with this place that once you start, you just don't stop. And I'm just so lucky that, again, I'm a product of this program. I graduated in 2014. And now we've graduated more than 100 people. And so today we'd like to honor the class that had the 100th fellow. I'm not going to pick which one is the 100th fellow because you're all important to us, as you know. But we'd love to give you guys some plaques. So Dr. Philipneri and I will be asking Usama Elewa to come up. We have Dr. Ahsan Usman and Dr. Yasar and we'd love for you guys to speak.
Oh, thank you, Dr. Vo, for giving me the chance to honor Dr. Martin today. It has been an honor to be part of the nephrology family in SLU. And when I say family, I really mean it. The care, the kindness, the support that we have here in the division, we can only see it in a family. Personally, I had a lot of circumstances that I had a lot of support and care from Dr. Martin and Dr. Vo and all the attending. So thank you. From the educational points, the program has a lot of smart and professional attendings, providing good learning opportunity to our junior fellows, provide like senior fellows the opportunity to practice independently and to be able be a good nephrologist in the future. For Dr. Martin, I don't know what word can I say for you. For me, and I believe as for many fellows, I've been like a good father, a good mentor, a good leadership. I learned a lot from you. And I don't know. Thank you, Dr. Martin, for being like a good listener, encouraging us, and creating good leaders and good professionals in nephrology. Thank you.
Hi, my name is Ahsan Usman, and I'm the privileged fellow, and I think it was a perfect timing that I joined the fellowship, and I got the award to become at the right time. And I also would like to thank you, Dr. Lentine, who invited all of us and arranged this event. And it's a very hard work, and I have I remember that I getting late night email from Dr. Lentine and then a follow-up email. Then, I mean, she has put a lot of hard work, and thank you, Dr. Lentine, and your team that arranged all this symposium. And then I woke up at 5 a.m. today, and I knew that I was coming here, and I have to say some good words for Dr. Martin. And I came up with brilliant idea to do Google search and to find my words what I want to say. But really, I'm convinced after 20 minutes of Google search that I cannot find words that I can put together and define that Dr. Martin has done so many years of excellent hard work and established this whole division. And this is like beyond description that I can say anything about the work that Dr. Martin has done over so many years. And also, I would like to mention about the faculty over here, and they are very welcoming. And when I came here, immediately I felt very comfortable to be part of the SLU team and nephrology division, ASOL, because it was well established and run by Dr. Martin and Dr. Vo. And when I joined, I remember that Dr. Vo also was an excellent program director, and she always go extra mile and treat all the fellows, regardless of their age, as her kids. And I was like a lot older than her, of course, but I mean, you know, from the age, I remember one thing during our rounds in the during the fellowship, Dr. Lee, and Dr. Mammoth, we were rounding in one morning, and one of the orthopedic surgeon came and he consulted us for hyponatremia secondary to SIADH, and the orthopedic surgeon came and looked at me, then he looked at Dr. Lee, then he looked at Dr. Mammoth, and we can see clear confusion on his face.
Who is the
Yeah, and then he could not resist. He said, "Can I ask who is the attending here?" That was, I remember that, and then, but I will would like to say at the end that I think this is a very good, very well established, very well run program, and its credit all goes to Dr. Martin for your hard work for so many years. And thank you for allowing me to come and talk. Yeah, thank you.
So my name is Yasar Caliskan. So I'm one of the now in transplant nephrologists here. So my journey started as an adventure in 2019. I was a faculty in Istanbul University, like 10 years of nephrology experience. With the rule of happy life, happy wife, and my wife wanted to live in US, we ended up with St. Louis University and started as a nephrology fellowship. I did clinic with Dr. Martin, and it was really great for me. The two things too important for me. First, I saw many mentors, but I think Dr. Martin is one of the smartest mentor I saw in my life. That's one of the things. Second, he is very encouraging because even in the field that he's expertise, he listens to you. And he listens to your decision and your approach. He didn't criticize any time, and I think that's why he built an encouraging program for everybody. Is very encouraging here. Nobody wants to discourage you for doing anything. Even sometimes I have impossible ideas, like Edwards, no, that they encourage you. Just say that, let's go for it. So I'm so happy, and I feel so fortunate to be a member of this family. Thank you so much, Dr. Martin, again, and also all the great mentors we have. Thank you very much.
We're going to go ahead with our next lecture. And we're really delighted to welcome Dr. Sharon Moe to join our program today. And as mentioned earlier, Dr. Moe is the Associate Dean of Clinical and Translational Research and Director of the Division of Nephrology and Stuart A. Kleit Professor of Medicine at Indiana University. Dr. Moe is well known for many achievements, including that she serves as the principal investigator for several ongoing basic and clinical research studies in the field of chronic kidney disease and bone and mineral metabolism. She's authored more than 300 publications and textbook chapters and has mentored numerous research and clinical fellows, and it's actually really exciting that our own Dr. Usaf was one of Sharon's early fellows. Dr. Moe served on the National Kidney Foundation's KDOQI Clinical Practice Guideline in 2003. She was co-chair of the International KDIGO Bone and Mineral Guidelines, released in 2009, as well as a member of the 2017 update. She was also a counselor for the ISN in 2005, and really notably, she served as president of the American Society of Nephrology in 2014. Outside of work, she's very engaged with her family, and we have here a recent picture of Dr. Moe with her mother at her mother's recent birthday party and her daughter, so 3 generations. And we're very delighted to welcome Dr. Moe to the podium.
Well, thank you very much for the kind introduction. So yeah, I actually drove I-70 yesterday from Indianapolis to St. Louis, and I'll be back today. And then last weekend, her 90th birthday party was in Kansas City. So we drove I-70 to Kansas City and back in one weekend. So I'm really sick of cornfields, although, we are getting done with that. So it's my pleasure to be here and to honor Kevin, who probably barely remembers my very first meeting. So back in the good old days when we were all advisors for all of these companies that were making every type of vitamin D analog you could imagine. There was an Abbott meeting that was in the top restaurant in the Hancock Building in Chicago. And it was me and Jill Lundberg as the 2 lone females and about 30 men, average age of 50 maybe, I don't know. So it was a little intimidating. I was just finished my fellowship, and it was very intimidating that. But Kevin and Jack Coburn were always so pleasant. So they always came up and welcomed, and just were very complimentary about our research, came up after talks and said, yeah, that's really great. Have you thought of this and that? And so it made me really feel welcome. And even though I have lots of older brothers, which is why I think I've never been intimidated of these kind of ratios in rooms, knowing that there's such a welcoming spirit when you're a young person who doesn't really fit in for that kind of reason is actually very positive. And I can see that he's had that same influence throughout the division by the diversity as well as just the wonderful attitudes of everybody. The other thing I like about Kevin is that he has this amazing way to tell somebody that they're wrong in a nice way. So that's a real skill as an administrator. And as a mentor, it's very important. So he'll just kind of say, yeah, that's kind of interesting. There might be something, maybe this and that, which basically instead of saying, you're wrong, it's this and that. So that's a skill set that I hope everyone that's actually been with him actually appreciates. So with that, I'll begin. My talk today is going to be about uremic toxins. So first of all, I do bone and mineral research, but I was told I couldn't talk about bone and mineral research because you guys all hear enough of that. So I decided to focus on this one, which is work that we're currently doing. And I fell into diet research accidentally. My parents both grew up in Nebraska and on farmland, and you had meat at every meal. So the concept of vegetarian diets was just absolutely foreign in me personally. But we have a rat model of progressive kidney disease, and one time I ordered the wrong food, and one had grain-based diet, protein, the other had a casein or a synthetic-based protein, and the progression of CKD and hyperparathyroidism was just dramatically different. I had no idea why, but I called up to Purdue, my nutrition colleagues there, and they went, well, of course, Sharon, that the grain is going to be less bioavailable or bioaccessible phosphate than is the casein or synthetic-based diet. So from there, I went, wow, seeing this, we did a quick crossover trial in the CRC and showed the same thing in humans, that when we gave them a vegetarian versus a meat-based diet with equivalent composition, that there was a marked difference in PTH, phosphorus, and FGF23. So I think that's what an MD scientist is all about, finding this thing in the lab and then being able to turn it around and see it in patients and go back and forth. And it makes a big difference to what we do with our patients long term. So that study, unbeknownst to me, thrilled dietitians galore around the world. I must have gotten 500 emails from people. So we can actually start giving our patients grain? And I'm like, this was a little crossover study, 8 out of 10, don't, you know. But what it also did is it attracted a lot of people who were into nutrition to actually come and work with me. And so I think I've been really blessed by a series of people that are into lifestyle modification, from physical therapists to exercise physiologists to RD, PhD faculty. I have an MD, PhD student that's starting with me in the spring, and when we were interviewing, he said her entire goal is to get a nutrition curriculum in medical school, because we do not teach medical students how to do a good diet history. They come to my stone clinic, like David said, and they actually are flabbergasted that a doctor actually asks them dietary questions. We also do not appropriately teach supplements. So supplements are so widespread. I just had a patient that came in with a bag full of them. And, you know, she had sudden onset of kidney stone while she was taking 10,000 units a day of vitamin D from Amazon. She was taking 3,000 milligrams a day of calcium. And she was taking all these turmeric is the latest hot herb, and it's full of oxalates. So, you know, it's really interesting when you go through it with patients what you can get out of that. So this is why I'm going to talk about the gut as being our mini nephron, because it actually does a lot more important things than we give it credit for. Okay, so I am not discussing anything of importance here. So you all know what CKD, mineral bone disorder, is. So it's a systemic disorder of, I see why you guys all stood up. It's really hard to, I'll just try to make it bigger. You couldn't figure out how to do it, David? Okay. Oh, well. No, I'll just stand here like David did. So, all right, so CKD-MBD is a systemic disorder, and this actually concept was from a KDIGO work group that we had, where we kind of discussed at that point, it was hard to do literature reviews because everything about renal osteodystrophy and phosphate and calcification was all intermixed, and there was no actually clear search term. Now, you might think that that's like, so what? But when you're doing clinical practice guidelines and you're trying to pull out papers, it's really, really critical that you have an appropriate literature search. So we came up with this name, and I think it's been a very, very good thing because it's actually broadened the scope of phosphate and calcification and PTH in bone and made it truly the systemic disease that it is. And part of that was the renaming of renal osteodystrophy to actually be to its Latin roots, in that is actually the pathologic differences in bone. All right, so these alterations, these biochemical alterations that we see in CKD and MBD are actually not at all harmless. So they end up, let's see, look at the ceiling, down here, gone, up in the ceiling, okay. All right, well, you can see it. It didn't work. All right, so increased FGF23 is associated with left ventricular hypertrophy. PTH can cause fractures. Increased phosphate is associated with progression of kidney disease and vascular calcification. And these all play together to give you cardiovascular disease. All right, so the biochemical relationships in CKD and MBD are really progressive. And so what we have is this wonderful compensation mechanism of increased FGF23 and PTH to keep your phosphate in a normal level. However, it gets to a point around CKD stage 3B to 4 where suddenly it is no longer adequate, and you start to see that rise in phosphorus. Now, if you look at the normal range for phosphate in your patients, you know, it's usually 3.5 or 3 to 4.9. You'll actually see a rise in that normal range, but it doesn't get flagged because it's still in the normal range. There's also a marked diurnal variation in the phosphate excretion, and so if you're measuring your phosphate different times of days in different clinics, you're not going to catch that rise in phosphorus. But unfortunately, that PTH and that FGF23 cause those problems. So what about cardiovascular disease? Well, this is a much older study from 2004 where you actually see that as your CKD gets worse, to the right, you actually have a marked increase in death, cardiovascular events, and hospitalizations. Now, what happens, though, is that the phenotype of that cardiovascular disease changes with advancing CKD. So atherosclerosis actually becomes less common. And all you fellows, how many of you have seen an ST elevation MI in a dialysis patient? You don't see it. It's gone. The patients who have severe atherosclerotic disease, unfortunately, die before they ever need dialysis. In contrast, what we have is left ventricular hypertrophy and sudden cardiac death as the main causes of death. So sudden cardiac death, so 50% of patients on dialysis die of cardiovascular disease, and of those, sudden cardiac death is 25% of those. That percentage is less than 5% in the general population. And it's not just from dialysis. The increased risk of sudden cardiac death goes up throughout the progression of kidney disease. Now, this is a slide that was like shown ad nauseum at ASN meetings in the early 2000s, but it really actually highlights a very important part. So on the darker blue, you see the general population, male, female, black, and white. And then you see this very light blue slide where you actually have this kind of flat line between male, female, and black and white. And so really what it is that advanced kidney disease equalizes sex and racial difference in cardiovascular death. So that kind of makes you think, well, wait, what's going on here that's uremic specific? Well, clearly CKD and BD may be part of that, but in addition to the cardiovascular disease, CKD and BD actually causes increased fractures. So similar to cardiovascular disease, for every, if you look at the black line, it's the increasing in the general population for hip fractures. And at every stage of CKD, you increase that risk, such that something is going on in advanced CKD to give you sudden cardiac death, left ventricular hypertrophy, and bone fractures. All right, so what happens at that point in time to cause this CKD and BD? Well, clearly there are uremic toxins. We talk about them. We have talked about them for how many years? And we tend to negate the fact that the kidney does a heck of a lot more than just clear fluid and water, which is all we really accomplish with dialysis and potassium. But there are a lot of other things, and there's actually, for fellows, there's an international working group of uremic toxins that has defined this. And every 3, 4, 5 years, they actually put together a more updated list that gives you all of these different toxins that accumulate in an impaired kidney. So some of them come from the gut and are not excreted, some of them just are not excreted, and some of them are actually made from the kidney. So this is the definition from 2003, and this is a more common or more recent paper from 2001. So basically, if you look through the updates, basically the definition of a toxin is something that is elevated in, you can measure it, first of all. Number 2 is that it's elevated in CKD versus normal. The third box down is that there's some sort of a negative effect of this toxin, in vivo, ex vivo, or in vitro. And the last one is that the biologically active concentrations in blood should actually conform with some sort of a disease state. Now, when we look at the different uremic toxins, we have endogenous produced toxins that are basically not cleared by the kidney, so they accumulate. Water soluble and protein bound. And these are the ones that we keep trying to remove with dialysis by adding these all sequential types of filters to do different things. One of them in particular was beta-2 microglobulin, which actually was my area of research as a fellow, quickly to be kicked out of any kind of relevance by the high flux dialyzers, which removed the majority of it. But if you also look at the top there, you have the exogenous derived, in particular gut derived. And this is actually, majority of these are protein bound, the ones that we know. There's a few that are water bound as well. So these are toxins that generate from the gut, get absorbed into the body, get usually sulfated or glycosylated by the liver, and then they're protein bound and they're not excreted, okay? So they accumulate. So this is an old list. Clearly, parathyroid hormone is actually a major toxin. It's an endogenously made toxin. It's an appropriate toxin in terms of going up, as we mentioned. It's physiologically secondary because it responds appropriately. And this is just my one slide on PTH, since I'm not talking about bone and mineral. But the point of it is that there's a lot of things that PTH does. And frankly, Kevin has done a lot of this research, and I don't know how he feels, but I feel like PTH was forgotten when FGF23 came around. And this is real, okay, PTH is indeed a toxin. And unfortunately, in the guidelines, and when we expanded the normal range because we didn't have data, everyone thought that you could have high PTHs and be okay. And we remember when the patients were fracturing and we did hand films and their bones were disappearing. So PTH is a toxin, and please don't forget that and minimize it, which is what I see happening. Okay, so how does PTH work? Well, very briefly, it does lots of things. We now know that parathyroid receptors basically sitting on the osteocyte. So when I was in medical school, the osteocyte was a dead cell embedded in bone, had no function whatsoever, and now we know it's actually the mastermind of bone. So the osteocytes stimulate circulating mononuclear cells to come down to the bone that needs to be resorbed to turn into an osteoclast to resorb the bone, and that's all mediated through the rank ligand. And then we have the osteobone lining cells that actually turn around and become big and plumpy and mineralize that bone. And about 10% of those cells actually go down and become osteocytes. They have a half-life of over 10 years. So they have this beautiful canalicular makeup that allows them to communicate with all the blood and also osmoreceptors and to detect gravity. So with all of this, they are truly a cell that has a lot of function in it, and PTH acts through that cell, not FGF23, PTH. Okay. Now, the rest of the talk, I'm going to stay away from MBG and talk about a different uremic toxin, in particular indoxyl sulfate. So, indoxyl sulfate is actually very high concentrations in patients on dialysis. So you can see it's one of the top in terms of the actual concentration in patients that have advanced CKD. It comes from gut, so it comes from 2 amino acids that are from the diet, and tryptophan in particular is then degraded into indole from gut microbiota, and then it is metabolized in the liver or the intestine to indoxyl, and then it's sulfated in the liver to give you indoxyl sulfate. P-crusyl sulfate is similarly altered in the gut from the gut microbiota. Okay, so just for terms, I didn't know any of this till I had Anna Baumbarit, who came to me and wanted to do microbiome work. So the microbiota are the actual name of the microorganisms. The microbiome is the environment of the intestine, and the metagenome is actually the genes at the microbiota. Now, I personally hated microbiology in medical school. It was just rote memorization, and everything that we learned in medical school is no longer the name they use now. So it's kind of one of those things that changes the definition all the time. But the point is that it is a really hot topic. So first of all, there is a study that showed that the microbiome or the microbiota in the intestine actually stimulate T cells that are important and are important in the anabolic effects of parathyroid hormone. So this is new data that I think is really exciting. Now the problem is studying this. So you either need to do a germ-free animal in a germ-free special facility. And so we've been trying this in our CKD animals, and what we find is that we see no difference in the microbiome between our CKD animals and our normal animals. And that is because they are in the same facility. Okay, so it's all their diet, but I can change that microbiome with any change in their diet. So that's where diet comes back in. All right, so tryptophan, okay, lots of over-the-counter supplements. Everybody doing muscle training, cardiac workout, they think they need tryptophan to build more muscle. I mean, lots of weightlifters come in with huge protein in their urine. I'm like, look, your kidney's smarter than you are, and you don't need that protein, but they still take it. And we tease about the tryptophan. This is coming up on Thanksgiving. We tease about the tryptophan insomnia we get. But the bottom line is that people are taking this stuff, including dialysis patients, and we don't know that they are because we don't ask. And so we are giving a substrate that actually is not cleared by the kidney when it's absorbed, or they are taking a substrate. All right, so what does indoxyl sulfate do? Well, to answer that question, you have to know how it binds and what it binds. So it is a ligand for the aryl hydrocarbon receptor. Now, what is that receptor? Well, it was actually identified with the dioxin disaster in India almost 45 years ago now. So basically what happened there is toxic gases came from a pesticide plant. Over 600,000 people were actually harmed by it. Generations have had consequences. No one knew how these drugs or how these compounds hurt the body. And that's when the aryl hydrocarbon receptor was identified. Now, it's a very complicated pathway. So you have ligands, of which indoxyl sulfate is one of many. It binds to a complex on the cytoplasm. You can see it's very complex in there. And then the aryl hydrocarbon receptor with the ligand is translocated to the nucleus, where it is dislocated and binds to an ARNT transcription factor. Okay, so what does that transcription factor do? Well, number one, it impairs mitochondrial oxidation. It can cause oxidative stress. It increases inflammation. It activates NF-kappa beta. And it downregulates the PTH1 receptor. So for years and years and years, we've been saying there's resistance to PTH, okay? So now we've actually have data, at least in vitro data, that the aryl indoxyl sulfate downregulates osteocyte and osteoblast parathyroid hormone 1 receptor. So this may be one of the reasons that we have that. So what happens with that? Well, it's been associated with cardiovascular disease, endothelial dysfunction, inflammation, muscle atrophy, and bone disease in both healthy and not healthy. So basically, you have a uremic toxin that gives you uremic symptoms, okay? But it's something that I will be honest, I hadn't heard of until we kind of got into this microbiome work. All right, so in animal models, so first of all, some of the other ligands are in the gray circle here. So the PCBs and all of these other things that we care about in the environment, we talk about, we don't want to take in, the plastic bottles with coating, they all are actually bind to the AHR. So the AHR receptor is so key in detoxifying environmental and chemical hazards. So what happens in CKD? We're actually basically activating that ligand with just lack of clearance of indoxyl sulfate. So in animal models, or on the outside here, in terms of cardiovascular disease. So pulmonary artery hypertension, myocarditis, I can't even read it on here, atherosclerosis, ischemic heart disease. There are animal models in all of this. So this is pretty big in the cardiology literature, but I haven't seen that much in the kidney literature. All right, so when we do elevated levels of free indoxyl sulfate, so remember it's protein bound, so you have to do free levels, they are associated with all-cause mortality, with heart failure events and fibrosis in the CKD rat that I'll show you, with prolonged QT interval and vascular calcification with both patients and rats. So in other words, there's at least associative data of high levels and these outcomes. So how can we reduce indoxyl sulfate levels? Number one, kidney transplant. Okay, yeah, I prescribe that for everybody every day. Just write it out on my pad and hand it off. I wish. Okay, AST-120. So this was a compound that is still actively used in Japan. It never achieved FDA clearance here. And basically, it's a kind of a ligand for the gut toxins. So it was using the gut to actually bind a lot of those toxins. And it actually effectively lowers that. And it's used in Japan where the lifespan of people on dialysis is really long. And it was very effective, but in the US, they decided to go after an indication of slowing progression of kidney disease in a trial of 1,000 patients, and it failed. Okay, clearly underpowered, but it failed. Fell out of this country, we can't get it here. But there's an alternative. We can alter the gut microbiome. So how do we do that? Well, we do it with antibiotics all the time. But with antibiotics, it's not really well controlled. We don't really have a say in what exactly changes. We can give a fecal transplant. I mean, how many people 10 years ago would have thought that we'd be given fecal transplants? I mean, gross. We're not in GI, are we? Urine's much better. And we could do fiber, okay? So fiber actually markedly changes the microbiome. All right, now I had no idea about this until Annabelle actually started working in my lab, but there are multiple types of fiber, okay? Not all fiber is created equal. So there are the psyllium, okay, your metamucil, which basically is non-fermentable, meaning that the bacteria can't use it. There is inulin, which is fermentable, meaning the bacteria can break it down and actually release toxins or release substances. And then there is both viscous and fermentable, which is like pectin. Okay, so these fibers all have different things. So when you tell your patient to eat fiber, what kind? I don't know. So we decided to look at inulin. All right, so we used our our slowly progressive CKD animal model. So on the left here is the original scan. So Vince Gattone, who actually did a lot of work in cystic kidney diseases and had like 7 colonies of different animals, called me one day and said, hey, I have a rat, I'm taking down the breeder, his heart is white, are you interested? And I'm like, of course, so I was doing a lot of vascular calcification. And this is actually that rat where we ran it through the CT scanner. And you could see the entire walls of the aorta, the coronary arteries, the valves are all calcified in white. Then we did EM on it, and basically it's hydroxyapatite. And then we did work in a paper where we showed that it's left ventricular hypertrophy and that the animals get sudden cardiac death and they get arrhythmias. Phosphorus was actually a very big factor in inducing this, but these animals get all this disease on a normal phosphate diet. And just for all of you that write grants, I wrote a grant, probably not about 18 years ago now, pre-FGF23, where I said phosphate is a toxin, a cardiac toxin, and one of the reviewers said, who cares about phosphorus? Cardiologists sure don't. So just to show you that sometimes you have better ideas than people can tolerate. Anyway, down here on the right then also shows you that you get cortical porosity, and that's actually probably due from the very high parathyroid AM. So the reason I like this animal model is I don't have to give high phosphorus to get calcification, but it mimics this graph I showed you earlier. So the top here is the CKD at 30-week animal and a 32-week, which corresponds roughly to 30 and 15 percent GFR. And so you see that the FGF really escalates in that difference between 2 weeks. You also see that PTH markedly increases in the last 2 weeks of their, and phosphorus actually goes from fairly normal to abnormal within that 2-week period. So we have this really accelerated period between CKD4 and end-stage CKD where we see all these dramatic changes that we're able to intervene at both of those time points. All right, so we actually gave the animals inulin. So the normal rat diet has 10% cellulose, which is the non-absorbable, non-viscous fiber. And we switch that out with inulin, which is the fermentable fiber. And what you see here is a marked decrease in the indoxyl sulfate. So for all of these slides, I'll show you the next couple ones. 30-week animals with CKD4 and 32-week on the right, and then the gray bars are the CKD animals with the cellulose, and the white bars next to it are the CKD that were treated with inulin. And what you see is that the indoxyl sulfate markedly went up, and that it was actually, that rise was dramatically lowered, not normalized, but lowered with the inulin in the diet. And we actually saw that it lowered serum phosphorus levels. We weren't expecting that. We've checked every transporter in the gut. It doesn't affect any of the transporters. So we're thinking that it affects some other factor in the gut. And with that, we get a marked decrease in parathyroid hormone, but no effect on FGF23, except early on. We have an increase, and I have no idea why at this point. So basically, you have a fiber that actually improves parameters of CKD and BD at the same time lowering indoxyl sulfate. It lowers several other toxins as well, but indoxyl sulfate is what I'm focusing on. All right, so this is the heart from those animals. So on the left is the normal animals, middle is CKD, and the right is the CKD treated with inulin. The top panels in pink are actually the fibrosis is in blue, and the bottom is the little black spots are all calcification. So what you're actually getting is arteriolar, not coronary artery, but arteriolar calcification that is then fibrosis around that. And you get enough of that, you can imagine if you got an electrical impulse through there that it's not going to transmit normally, and I personally believe that's what our arrhythmias are caused by. And in fact, when I collaborate with my cardiologists to do a lot of electrophysiology on the animals, we do indeed see basically impaired conduction. And then on the top right is aortic calcification, where we again slowed progression, and even heart calcification was markedly decreased by inulin. In the bottom, we look at the bone. So we see a decrease in the cortical porosity, we see a decrease in the osteoclast, but no change in the total bone volume. So it helps cortical bone, which might be from the PTH, but not much effect on the trabecular bone. And that's probably because it's so much more of the bone volume and why you get that. So how can we reduce the indoxyl sulfate levels? Well, we can give the kidney transplant, as I mentioned. We can give this AST-120, but we really can't. We have to go to Japan to give it. Or we can give fiber. So think about that. What a simple treatment, right? Give fiber to our dialysis patients who are already constipated and need something anyway for that. We can give them a bar. In fact, what can we give? We can give a fiber 1 bar. It's my new prescription therapy. So a fiber 1 bar has 5 grams of dietary fiber. It's the right kind of dietary fiber. It does have a little teeny bit of sodium and a little bit of that, but that's my next transition from rats to patients, is to do a randomized trial of fiber 1 on dialysis versus not, looking at indoxyl sulfate levels. Because how simple can it be to give them that? And we could be feeding them that with the dialysis patients. And my postdoc, who's now a faculty at Purdue in nutrition, Annabelle, has actually done it, and she gave straight inulin to patients on dialysis, and they did tolerate that pretty well, but it does cause a little bit of diarrhea and gas and that kind of thing as well. So we just don't know how much they need. And we've tried to look at every book in the literature to figure out how to extrapolate fiber content in humans from rats and vice versa, and we can't figure it out. So if anybody knows that, let me know. But what a simple cure, and this is what we need to do in nephrology, is think more about the gut, think more about the diet, because these are modifiable things, and we have patients who just want to not take more pills. They want to take something simple. Anyway, and that's it. So uremic toxins and cardiovascular risk, maybe we need to use the intestinal one. Thank you very much.
We're getting very close to our keynote address, but first we wanted to welcome Dr. Nayak and Dr. Montaño to present a service plaque to Dr. Martin. Thank you so much for joining us.
Hi, you're having a good time so far? It's an honor and a privilege for both Dr. Adriana, Montaño, and me to present the service award to Dr. Martin today. And I would like to thank Dr. Edwards, Dr. Lentine, and all the organizing members for giving us this opportunity. So what can I say? Life has come full circle. I knew about Dr. Kevin Martin in India before I even landed in the United States. So I worked with his former fellow, colleague, and mentee, Dr. Sudarshan Balal. And some of you may know or may not know, I worked as a registrar of nephrology for almost 2 years. And he used to talk about Dr. Martin all the time. And so I'm a second generation mentee, even before I landed in the United States. And that motivated me to pursue American Dream. I landed here in 1995, and I worked with Dr. Esther Gonza since 95, and I mentioned to the crowd yesterday that she was the first one to give me the David Burton Rose book and introduce me to Up to Date. So Dr. Martin is a classic triple threat, academically speaking. He is an outstanding clinician, fabulous teacher, and a highly impactful researcher. But I would like to add 4 more things which are more important than these accomplishments, because all of you have spoken about that a lot. First, I consider him to be a pinnacle leader. If you go by John Maxwell's book, it says the best leaders reach the level 5 level of leadership that's called pinnacle leader, where a leader creates the next generation of leaders. And he's a charismatic mentor for many of you, and this symposium is a testament to the love and affection you have for him. And the next one I would like to say is he's a pragmatic innovator, and we heard about this throughout the conference. When there was a need, he innovated. He created an interventional nephrology service. He recruited talented faculty for transplant nephrology. And the next one is, this is near and dear to my heart. He's probably one of the best and extraordinarily smart physician leaders. And we need physician leaders, otherwise administrators will run our lives, And that he does that due to his business acumen and insights in this world of fast-changing medical and healthcare field. And he's a collaborator, and we heard, and he has been on editorial boards, been on the hospital committees, regional committees, national committees, and international committees. And he has tremendous respect from community nephrologists. And he builds bridges with the community nephrologists and brings them back as a faculty or builds relationship with them. And that's how we created dialysis service at St. Louis University. And I would like to mention all the young leaders here. He's the gold standard to be a division director. He came to St. Louis University in 1989. He was the division director here and also the section chief at the VA Medical Center. So he was probably heading a startup at that time. It was a bare bones division. And now look where we are. He has created an internationally known division of nephrology with 100 fellows. And his impact is all over the world. And I mentioned Dr. Balal here earlier. Now he runs 40 hospitals, 2 med schools, and several other programs. And so for any chair of medicine, he's like a Berkshire Hathaway stock. Once you have it, you never give it away. Once, on a personal note, I would like to thank Dr. Martin for his mentoring and his friendship and counseling me, especially during past 5 years as my tenure as an interim chairman of the Department of Medicine. And we have become a lot closer, and our friendship has become stronger. And he has taught me the valuable lessons. He always stays ahead of the curve. And whenever he speaks, all of you must listen. Because he speaks few words, but they're all golden. You don't agree with that? So we are talking here about his 50 years of journey, but I personally feel, and this is how I always, his legacy will live on for more than 100 years. Think about it. The leaders he has created, the 100 fellows, and they train the next generation. So your impact will be huge and long-lasting. And it is a pleasure to hand over the service award with Adriana, and she will speak a few words about your research collaboration work also. Thank you.
Thank you so much. It's a privilege for me to say some words about Dr. Martin. Thank you so much for being here today. So Dr. Martin joined St. Louis University as the director of the Division of Nephrology in 1989. By that time, he had already established himself as a substantial and productive clinician and researcher with more than 80 research publications to his credit that time. He had benefited enormously from the intellectual and background that characterized the Washington University Division of Nephrology under the direction of Dr. Saulo Clark, and from the productive mentorship from Dr. Eduardo Stakopolsky. He clearly aimed to transplant elements of that environment to St. Louis University. Here, Dr. Martin established his research laboratory at SLU and continued his NIH-funded research on metabolic bone disease of chronic kidney failure and its endocrine matrix of regulatory pathways. Important foci included work with vitamin D analogs, calcium mimetics, and the role of bone biopsy in managing renal osteodystrophy. As he continued to develop his own research interest, focused on the metabolic bone complications of chronic kidney disease, he also recruited a series of investigators and nurtured the development of their own research programs, which have had their own substantial impact. In doing so, he transformed the SLUNephrology division into a nationally and internationally recognized entity that has made substantial contributions to a broad range of advances in nephrology, from basic science to clinical applications. Prominent among the independently funded investigators who have been members of the division faculty under Dr. Martin's leadership include Paul Schmidt, Bahar Bastani, Esther Gonzalez, John Edwards, Michael Rochman, Siad Al-Ali, Krista Lentine, Maggie Gallants, Quan Li Chi, Marie Philipneri, and Tarek Al-Akhtar. Some of Dr. Martin's most impactful work came about due to his willingness to work with sponsors from industry. So thank you so much for the sponsors today as well. his investigations of circulating forms of parathyroid hormone contributed to the commercial PTH assays that are in use today. Overall, Dr. Martin transformed the renal division at SLU. His legacy of rigorous and joyful pursuit of knowledge lives on here and broadly through the generations of the nephrologists he has mentored. We are honored at St. Louis University to have you. Thank you so much.
I'm grateful for all those nice things you said about me, and I'd like to spend the next hour or two in a rebuttal. So really what I thought I'd do is I really just want to review this 50-year span of me in nephrology and how times have changed. And I'm not going to review in any detail really all of my CV and the like, which has been addressed earlier. But I graduated from medical school in 1971 and began as an intern in this renal and metabolic unit. And that kind of was a good opportunity for me because it reaffirmed my interest in nephrology and also endocrinology. And actually, I was leaning more towards endocrinology at that time because I liked physiology and feedback loops and that sort of thing. But as time went on, over the next year, I did have an interest in academic medicine, and the opportunities in Ireland for that were extremely small. Someone would have had to die to create a vacancy in those days. So I decided I would come to the US and to see if I could establish myself in academic medicine. So I pulled all the strings I could and ended up with a position at Washington University, but it was in nephrology, in the renal division. And I thought, well, I really wanted to do endocrinology, but I could probably do nephrology. And as it turned out, I think it ended up with the best of both worlds, because I think now nephrology is a better clinical specialty than endocrinology, because in those days, endocrinology was heavily weighted at diabetes, and we only had early versions of insulin, and either gave a little more or gave a little less, and it wasn't very intellectually satisfying, unlike today, where there's a gazillion drugs for diabetes with broad spectrum of activities and various comorbidities that have really changed the landscape of diabetes management. But I learned important lessons along the way before I came here. The first one was the importance of primary information. And I just want to tell you one little anecdote about that. As an intern, and in those days you could admit people to the hospital to evaluate them and work them up. So I had this woman that came in her early 50s, 52, and she was in for hypercalcemia. And in those days there was no PTH assays. The diagnosis was somewhat difficult, and the attendings only came by maybe once or twice a week. So we rounded on the Monday. I presented the case, and he said, you tell me how you're going to work it up, and we outlined that. And he said, well, I'll be back on Friday. So we did the best we could in trying to work it up, but when he came back on Friday, he said, have you made the diagnosis there? And I said, no, but we were kind of interested in trying to show that PTH changed bicarbonate thresholds in the kidney. We were working through that with some technical difficulties along the way. So I said no, and he said, well, I have, and I've scheduled her for a neck exploration on Monday. So that was really devastating to me because I had no idea. How did he know that? So it came to Monday. She had her neck exploration. I called the surgeon, and indeed he had found a parathyroid adenoma. So we had a tradition then in the unit that we had a cup of tea at 10:30 every day and at 3:30 in the afternoon. That was sort of typical Irish tea drinking. So in the afternoon tea, I asked him, how did you know that? And he said, well, on my way home from after you presented the case to me, I was driving by the maternity hospital. And I remember you told me she had 2 children, one 6 and one 8. So I popped in there on my way home. There was no HIPAA or anything like that at those days. And I looked at her calcium, and when she delivered the last baby, her calcium was 10.6 and 10.4. And I don't know any other cause of chronic hypercalcemia in an otherwise healthy person other than primary hyperparathyroidism. So that was really the lesson. I drove home that way every day. I could have gone into the hospital. I didn't, because that was just something I didn't think of doing. And the lesson was that you should do what you need to do to get the primary information, and it actually can be helpful to you. So after I came here, in advance of my nephrology fellowship, I had to do a year of internal medicine. And my intern was Jeff Gordon, who you probably know as sort of the father of the microbiome research and may even be a candidate for the Nobel Prize for all he has done. He was an extremely smart guy. So we had a patient in with severe asthma, just wheezing away, and he was my intern, so I asked him, how are you going to treat it? He said, well, I think about asthma in terms of cyclic AMP. So I'm going to give agents that increase it, and if necessary, agents that decrease its degradation. So that was beta-adrenergics and theophylline. And I thought that's really good. You know, that's to think of it that way was really important. And so it really brought home the lesson was if you can define the mechanisms of the disease, then you can target that and you should get good outcomes. And as it turned out, that was really the theme of the Department of Medicine at Washington University in those days, where all disciplines were focused on trying to understand mechanisms so that you could plan a rational approach to treatment. So it was extremely important lesson to learn, and actually has continued really throughout these last 50 years. But probably the most important lesson was the importance of a really great and active mentor. And I was lucky to meet Dr. Sladopolsky, who had a terrific, charismatic personality, very social, and very passionate about pathophysiology. And he was great for me because he really went out of his way to introduce me to everybody he knew in nephrology, and that was virtually all of them. So I met everyone. He socialized with them. We met all the giants in nephrology, and he really would promote my career in many ways, where he would turn down invitations and suggest me to go instead and the like, and just to make sure that I achieved some recognition. He also taught me the important lesson is don't fight over authorship on papers. It doesn't really matter at this stage of my career. He said, people will know who's doing the work, so just be patient. And I think that was good advice too, because so many people get so upset whether somebody changes the author order in the paper. And really, people do get to know who does the work, and so it all sorts itself out in the end. So he was great to me, and it was a terrific interaction over many years that really helped develop not only me but many of the other fellows as well. During this time, and Aubrey and Marcus will remember this, and Steve maybe, that we had a Saturday morning conference every Saturday morning that lasted 2.5 to 3 hours, and everybody came. All the fellows there. Can you imagine that happening nowadays? The times have really changed, but we were in a time where nephrology was a relatively new specialty. The focus was in defining the physiology of the kidney. And all of that was directed towards that. And the division director, Saulo Clara at the time, really gave all these conferences himself. And we were fortunate to have some faculty members like Herschel Harder, you remember Herschel? Who was a good substrate for penetrating questions. And he took the load off a lot of us, really. But it was important to have that kind of environment where we all learned from each other. And as I said, now I don't think there's any chance of such a thing happening again. So we have to find other ways to do that and maintain the interaction among people, because so much learning is from casual interactions, really, and ideas and questions and other conversations that might lead to future ideas. At that time, it was the early days of dialysis. Dialysis was really just starting. And we were, as fellows, not fazed at all by walking into our little acute dialysis unit where there was a huge common bath of dialysate, and we met with pink foam coming over the edges as the dialyzers ruptured, which they did with regularity. But things improved gradually after that. Funding came for outpatient dialysis. We had committees to decide who gets dialysis and who didn't because of limited resources. But it rapidly progressed. And then over those next 10 to 15 years, dialysis technology improved a little bit and then has stagnated, basically, I think. But as you talked about earlier, some of the things that happen and all of the things the kidney does can hardly be handled by a synthetic plastic membrane. So hopefully progress will be made in that area. Now, the domination of outpatient dialysis by large companies has really facilitated that stagnation, and everything is just about economics rather than trying to improve dialysis itself. And hopefully that can change too. But while all that physiology was being developed, there was also, in nephrology, was the back room efforts to try to make therapeutics. And one of the first landmark therapeutics that arose was the discovery of recombinant DNA techniques and the synthesis by that means of erythropoietin, which then made it possible to correct the anemia associated with chronic kidney disease. And then we learned as a discipline that most of the symptoms that we had attributed to uremia were actually symptoms of anemia. And from a historical note, our target hematocrit for transfusing a patient was 15 to 18. So you'd let them run down to that level before you'd ever give them a unit of blood. And so the patients underwent a lot of hardship in those days. There were many of which were rapidly corrected by the administration of erythropoietin. Nephrology was way behind and still is in terms of organized clinical trials that changed the practice. For example, if hematology, oncology is number one, we're not even in that ballpark at this time. So one of the first really landmark clinical trials that came in the mid-90s was the MDRD one, which, as you know, spawned the development of equations to estimate GFR. This was actually designed, what Sharon mentioned, towards answering the question if reduction in protein intake would really help the progression of renal disease. And there may well be other reasons for that, and the effect was very modest, and it sort of fell out of favor then, not to radically restrict protein, as was the practice before that time. And then the ACE inhibitors came along, which was, again, shown by clinical trial to be effective in showing progression, and followed shortly thereafter by the ARBs. And then it seemed like nephrology was entering a phase of being able to develop actually useful therapeutics. So in our own field of bone and mineral research, there were advances in phosphate binders, changing from one to another as various toxicities were discovered. Based on parathyroid physiology, calcimimetics were developed, and they were useful. We went through years of vitamin D analogs trying to find less toxic vitamin D preparations. And our field again seemed to stagnate a little bit, waiting for other developments for other aspects of kidney disease that might be impacted. But that really did change after another decade with the advent of the potassium binders, which I think everybody would agree have been a great addition to clinical practice. And now we've gone on to the remarkable biology of the SGLT2 inhibitors with pleiotropic effects on many organ systems and also affecting the progression of kidney disease in a favorable way, and maybe even beginning to affect cardiac complications of chronic kidney disease. And a similar field is developing for the GLP receptor agonists that are also used for diabetes. Again, with all of the development of basic mechanisms in the background, we're on the horizon of the use of these hypoxia-inducible factors, the prolyl hydroxylase inhibitors, one of which finally got approved this week for use in patients on dialysis, with two predecessors not making that grade so far. And then the basic science has led to other therapeutics, the difelikefalin for itch based on interactions with opioid receptors, and the non-steroid mineralocorticoid antagonists, which also will have a role in slowing the progression of kidney disease, although the effect is also a bit modest. And we're on the brink of really future developments that are going to change the landscape of kidney disease. Cell therapies are being explored with very interesting preliminary results, which and hopefully we'll be starting and participating in that study soon. Targeted therapies are coming almost weekly, particularly in things like lupus nephritis. We're progressing with biomarkers for a variety of disorders. There's also potential advances in therapeutic agents for acute kidney injury, and hopefully they may come into the clinical arena. There's been advances in transplantation, maybe the cusp of xenotransplantation a little bit. And of course we heard all about the vascular access from Dr. Mawla today. And the other intervention thing that we might have to add to the portfolio is this renal denervation for hypertension, which is now benefiting from improved technology that can achieve this in a more reproducible way, with at least fairly spectacular short-term results, and we have to wait and see how that goes in the future. So it's been all of this has happened, and I've had the pleasure to have this group of terrific faculty which has helped us develop these initiatives along the way. We have a bunch of former faculty who were here for a while and then moved on, mostly to bigger and better things, as we've replaced some of the core faculty that we still have at this time. So it's been a pleasure to have all this group of nephrology, and as was mentioned over and over, the word family keeps popping up here, and I think we really do have a nephrology family, which is very, very useful. So I want to really conclude with some thanks. I want to thank John for making this morning's session happen. He got Krista to jump in there to put her tremendous energy into it, which she did, and you can see the product. She was ably helped and abetted by our two PAs, Ariel and Amy, who did a ton of work, and it all perhaps came together in the end. We've had great interaction with the fellows. I really appreciate those that have left our program and graduated and who made the effort to come back here today. I want to give a shout out to one faculty member, Dr. Vo, who really took on the fellowship program when it had dwindled a little bit, and with not much pressure, really. You jumped into this and really have made a tremendous change in the fellowship program, and your hard work and enthusiasm has been just outstanding in that regard. And that's really, the whole fellowship program is what the engine that drives the whole nephrology enterprise that we have here. And so I can't stop thanking people without thanking my family. And two of my older children are here today, and my one younger. There's two others in the older group who couldn't come. But I think they all put up with me over the years and really facilitated all of the time and interest and time away that I took for the developments in nephrology. And the final word really to Esther, who has also put up with me for a long period of time, and she has tolerated that, and I thank you for that. So all in all, it's been a great 50 years. It's something that I'll probably miss, but hopefully we can do some other things and stay in contact for a little while. So thank you very much for everybody coming today. I really appreciate it.
Wanted to thank everyone so much for joining us for this inaugural symposium. We wanted to make everyone aware of scanning the codes both for attendance and for evaluation. That's really important to get your continuing medical education credit. We do have box lunches over in the exhibit hall and some ongoing attention with the exhibits, as well as some ongoing activity for SLUNephrons. I did want to, again, emphasizing the thanks for the program committee. I wanted to ask Amy, Ariel, Dr. Caliskan. We have one program committee member actually that I really wanted to shout out because many of you may not know him. Ken Mayer is a public health and a pre-med student who's been really an operations director with me on this and has spent really literally hundreds of hours.